लता हाँ लता क्या पढ़ रहे हो लता मीटिंग रहता है मीटिंग है इसलिए नहीं गुड मॉर्निंग
కాలేజీలో ఉన్నాను. எவ்வளோன்னு பார்க்கலையா? ம்?
தம்பியை விட்டுட்டு வரும்போது ரோல் மீட்டிங் கேட்டாங்க.
Sir, Sengatone sir, good evening sir.
Good evening, good evening.
Happy New Year sir.
Same to you.
Happy New Year, sir.
Happy New Year, thank you.
NSB sir, Happy New Year sir.
சார் செங்கட்டூன் சார் குட் ஈவினிங் சார்.
Good evening, Nini. Good evening.
நல்லா இருக்கீங்களா
எப்படி
சார்?
இருக்கு?
நல்லா
டாக்டர்
இருக்கீங்க
எப்படி இருக்கிறாங்க?
நல்லா
கல்யாணம்
இருக்காங்க
டாக்டர்
சார்,
எப்படி
நல்லா
இருக்கிறாங்க?
இருக்காங்க சார். எல்லாம் நல்லா இருக்காங்க சார். ரொம்ப தேங்க்ஸ் சார். தேங்க்யூ சார். நிர்மல் சார் குட் ஈவினிங். நிர்மல் ஃப்ரெட்ரிக் சார் குட் ஈவினிங்.
இருக்க கூட யாரு கொடுக்கணும் சார்? நேமிநாதன் சார், குட் ஈவினிங் சார்.
குட் ஈவினிங் சார். குட் ஈவினிங் சார். நல்லா இருக்கீங்களா சார்?
நல்லா இருக்கேன் சார், நல்லா இருக்கு சார். வெல்கம் சார்.
ஹாப்பி நியூ இயர் சார்.
ஹாப்பி நியூ இயர் சார். ஹாப்பி நியூ இயர் சார். செக்ரட்டரி சார், திரவியம் மோகன் சார், குட் ஈவினிங் சார்.
Good evening, sir. Good evening.
குட் ஈவினிங் சார்.
Good evening, Dravyam.
Good evening, sir.
Good evening, Nirmal.
Thank you, sir. Thank you for joining us.
திரவின் மோகன் குட் ஈவினிங்.
Good evening, sir.
Good evening, sir. Good evening, sir.
ஹாப்பி நியூ இயர். விஷ் யூ ஆல் தி பெஸ்ட்.
Good evening, sir.
Good evening, Dravyam.
Good evening, sir. Good evening. President வந்துட்டாங்க சார்.
இன்னும் பிரசிடென்ட் வரல.
Good evening, Nirmal.
Good evening, sir.
All the
Good
best.
evening, Abu.
Chairman, thank you.
All the very best.
Good evening, sir.
நல்லா பண்ணுங்க.
குட் ஈவினிங் அபுல் சார். குட் ஈவினிங் சார்.
Good evening, good evening.
ஹாப்பி நியூ இயர் சார்.
Wish you the same.
Sir, good evening, sir. Sir, can we start, sir?
Good evening, Sandil.
Sir, good evening, sir.
ஸ்டார்ட் பண்ணுங்க, சரியா இருக்கும்.
Yes, sir. இப்போ ஸ்ரீதர் சாருக்கு மட்டும் ஒரு தடவை பேசுங்க.
ஸ்ரீதருக்கு ரிங் கொடுங்க.
செந்தில் குட்
Just
ஈவினிங்.
reminding.
Sir, good evening, sir.
Solomon sir, good evening sir.
Good evening, sir.
Happy New Year sir. Happy New Year.
Happy New Year. Happy New Year.
Good evening, Solomon.
Good evening, sir.
சாலமன் சார் குட் ஈவினிங்.
Good
ஹாப்பி
evening,
நியூ
sir.
இயர்.
Happy New Year, sir.
தேங்க்யூ.
Bye.
Join a personal meeting.
Dravyam sir, please permit me to share the slides.
Meeting.
Please make
Sir.
me co-host. Please make me co-host.
சார் அது அவங்க தான் பண்ணும் சார் ஏஎம்எஸ்.
Sir, good evening. 1 second, sir. 1 second. I will.
Yes, sir. Chaladurai sir, good evening.
Good evening, sir. 1 minute.
Sir, Sridhar sir joined, sir.
இருக்கடா செல்லம்.
Sridhar sir, join ஆகலைங்க sir.
joined.
Oh, join பண்ணிட்டாங்க.
Sir,
Sir, good evening, sir.
sir.
Sridhar sir,
Good evening, sir.
Good evening, good evening.
Good evening, sir. President, sir. Good evening.
Good evening, Gauri. Good evening.
Good evening, all, sir. Good evening.
Good evening.
Sangutana, good evening, Sangutana.
Sir, good evening.
Good evening, Dr. Sridhar.
Good evening.
Good evening, good
President,
evening.
sir. President, sir. Past President, sir.
Welcome, Jailal sir.
Ravi,
Good evening,
good evening,
Ravi.
Ravi. Ravi Kumar, good evening.
Nemi, good evening.
பச்சை நிறமே பச்சை நிறமே
Welcome song, President.
ரவிக்குமாருடைய சட்ட நிறம் ரவிக்குமாருடைய சட்டை.
Good evening, sir. Ravi Kumar, sir. Good evening.
Good evening, sir. Good evening.
Happy New Year.
Can we start?
Yes, sir.
Yes, sir.
I think we'll start.
Sir, shall we start, sir?
Yeah.
Blocked.
Prayer.
பெயர் வாழ்ந்தது சரி, இதுல பேர் பண்ணிப்பாங்களா ப்ளூ?
ஒருவேளை அதை கேன்சல் பண்ணா வருமா? ப்ளூடூத் ஆஃப் பண்ணி பார்த்தேன். வேண்டாம், இதுலயே
Sir, Chaladuri sir, can you just mute all, sir?
இதுலயே வரலையே உங்களுக்கு முதல் மீட்டிங்.
Okay, welcome everyone. We'll start the proceedings of the AMS wing of IMA TNSB with IMA prayer. Sandil?
Yes, sir. Sir, I request our Honorary State Finance Secretary, Dr. Solomon Jaya, sir, to give IMA prayer and official prayer.
Okay. IMA prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and love. Physician prayer. Dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift come from thee, I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child I rely on thee.
Thank you, sir.
Thank you, sir.
Thanks.
Thanks, sir. Now I request our chairman, Dr. Nirmal Frederick, sir, to give his welcome address.
Thank you, Sandil. Respected President, Dr. Sridhar, Dr. Thiravyam, Secretary, Dr. Solomon Jaya, Treasurer, respected Senguttuvan, sir, immediate past President, the President-elects, Dr. A.K. Ravikumar, NRTR, Dr. Karthik Prabhu, Dr. Solomon Jaya, and I call a host of leaders who have joined us, Dr. Jayalal, and all the senior leaders, and my dear AMS colleagues, Dr. Sendil and Dr. Mohammad Ibrahim, our esteemed faculties today, Dr. Neminathan, Dr. Raghunandan, and Dr. Suresh, and all the delegates who have joined after a wonderful response to our call for joining this meeting. A very good evening to one and all. On behalf of the AMS wing of IMA Tamil Nadu State Branch, gives me great pleasure to welcome you all to this inaugural CME, the first AMS academic program of this year. So this program is special for two important reasons. First, it is our first CME under the new leadership of IMA TNSB team, led by our dynamic state president, Dr. Sridhar, the secretary and treasurer team. Second, it is also the first major academic initiative of our newly formed AMS team, and we are committed to strengthening academic activities across specialties. We are thankful to all the guidance, support, and encouragement, encouraging response, overwhelming response from over 1,500 doctors, participants who have given us a thumbs up with their registration. The theme of today's CME is infection, a topic that is relevant to every clinician, every specialist, and infection continue to challenge us in daily practice, whether it in pediatrics or ophthalmology or any other rational antibiotic selection. Understanding the basic broader One Health concept is important, and that is the reason why we have selected this as the inaugural CME. And we have wonderful speakers and faculty to lead this topic with us. So I welcome these speakers and also thank them for sparing their valuable time and expertise. I also take this opportunity to appreciate the efforts of our AMS team, especially Dr. D. Sandil Kumar, Secretary, and Dr. Ibrahim for organizing this program smoothly. And dear delegates, your participation is what makes this CME meaningful. Let's make this interactive. I'm confident that today's session will be informative, practical, and enriching. So with these words, I once again welcome you all and wish the program success, and a warm welcome to all the delegates to our inaugural meet. Thank you.
Thank you, sir. So now I request our State President, Dr. Sridhar sir, to give his presidential address and also inaugurate the CME.
Thank you, Dr. Sendil and Dr. Nirmal. The most respected immediate past president, Dr. Sangutu Anna, my own team, Secretary Dr. Mohan and Dr. Solomon, the previous team, Dr. Karthik Prabhu and Gauri Shankar, President-elects Dr. Ravi Kumar and Dr. NRTRT, all the leaders of IMA along the line, including Dr. Jayalalji, the new team just taken over, Dr. Nirmal as chairman and Dr. Sendil as secretary and Ibrahim as joint secretary. It's a great pleasure to be with you all for the inaugural AMS event of the year 2026. And for the past 2-3 years, we have seen excellent work done online by both CGP and AMS. And our academic wings have really picked up speed and power. And nowadays, the topics covered are all up to date and very useful and evenful for those people practicing outside institutions in the periphery, rural and semi-urban areas. And in that way, IMA TNSB is very proud to say Tamil Nadu has one of the strongest teams of academic CGP and AMS across the country. And today's attendance, registered attendance of 1,500 and current attendance of around 508, really speak volumes for the interest we have created online in the minds of the practitioners across Tamil Nadu and across India. And I'm very sure the first topic, infection, holds a lot of meaning with a respiratory or throat infection cutting across Tamil Nadu. I think Dr. Neminathan will agree. There has been a throat infection going on with severe cough, not relenting to any antibiotics, probably a viral one. And the Tamil Nadu government declaring the recent modified coronavirus that is going on in the state. A few days back, our health department made an announcement on that. And so I think it is only right that we have taken up will benefit a lot by this way. And the leading speakers will throw light on the current concepts and approach to management of infection. So with these few words, I wish the event great success and more successes to come by to the team IMA AMS. Wish you all the best. Since I am talking to you for the first time in 2026, I wish you all a very happy and prosperous 2026. Over to Sendil.
Yeah, thank you, sir. Now I request our State Secretary, Dr. Ravi Mohan sir, to give his address.
So, good evening, all. Respected President, respected Finance Secretary, President, immediate past President Dr. Sengutun sir, President-elect Dr. Ravi Kumar sir, Tyagarajan sir, immediate past Secretary Dr. Karthik Prabhu, and Common President Dr. Jailal sir, and the distinguished guests, colleagues. I'm extremely happy to be a part of this first online CME program. As you all know, under the extreme leadership of Dr. Nirmal Frederick as a chairman, and you all know about Sendil Kumar, who is very good at organizing these meetings. The Sendil Kumar is the organizing secretary, and Ibrahim is a joint secretary. I am very happy to be a part of the first online CME. This meeting embodies the vision of the team, that they have thoughtfully selected the topics. I am confident this AMA team will achieve remarkable and establish strong academic benchmarks. In today's topic, infection, we are honored to have with us Dr. Neminathan, a senior pediatrician, a very active clinical pediatrician, Dr. Suresh Kumar, an infectious disease specialist, and our esteemed teacher, Dr. Raghunandan, whose experience and guidance continue to inspire us all. On behalf of the IMA Tamil Nadu State Branch, I once again extend my best wishes to the AMS team for a successful and an impactful academic journey. Thank you.
Thank you, sir. Thanks for your kind words. And now may I call upon Dr. Jailal sir to give us few words of felicitation.
Thank you, Sendil, and
Yes, sir.
leaders of Indian Medical Association, our beloved president, and distinguished faculties. It is indeed a great honor and privilege for me to attend the program. I'm extremely delighted, extremely happy to see the growth of academic wings in Indian Medical Association. That is one of the most attractive and needed phase of Indian Medical Association, which is going to help a lot of people, both our doctors and also the community. Today, IMA Tamil Nadu is fortunate to have the leading stars in the AMS. Dr. Nirmal is well known for his academic activities, quality work, and proactive activities, foreseeing the future needs and appropriately propagating it and projecting. It's all that talents with Nirmal is having. And Sendil has proved his mantle both as a IMA CGP secretary and the chairman, and has done extremely well and given a new dimension to the online webinars program. I'm amazed to see that is most of his programs were all in cross the 4 digits of thousands and 1,500. So that is a great asset for IMA, and we have a lot of learned speakers, both Neminathan and Raghunandan, all are extremely well popular figures for knowledge propaganda in our state. So putting all of them together and bringing in appropriate subject is always a pleasure. I am extremely delighted to see the growth and the appropriate actions of our AMS. I wish and congratulate the AMS, equally the President Sridhar and his team for this extremely good work. I only appeal to our doctors, colleague, that please utilize these opportunities, update your skill. Definitely it will go and empower yourself in the society and help our community. So wishing you all the best for the endeavor. I'm looking forward to hear the words of wisdom from all the three speakers and eminent speakers of this day. Thank you very much.
Thank you very much, sir. Now I request our immediate past president, Dr. P. Sengutun sir, to give his words of felicitation.
Thank you, Dr. Sendil. Good evening to everybody. Respected President Dr. Sridhar, Honorary Secretary Dr. Dravya Mohan, Finance Secretary Dr. Solomon Jaya, AMS Chairman Dr. Nirmal Frederick, Secretary Dr. Sendil Kumar, Joint Secretary Dr. Ibrahim, my Honorary Secretary Dr. Karthik Prabhu, Past Honorary Secretary Dr. Karthik Prabhu, Gauri Shankar, and President-elect Dr. Ravi Kumar, Dr. NRTR, and the Commonwealth President Dr. Jayalalji, and distinguished speakers Dr. Neminathan, Dr. Raghunandan, Dr. Suresh Kumar. First of all, my happy new year to all the members, and I wish the present team led by Dr. Nirmal Frederick will throw more lights on the AMS program and continuous teaching programs every month. and it will be useful to all the delegates who are registered here, and they will utilize the opportunity so that it will be useful for your common practice. Today's speakers, Dr. Neminathan, Raghunandan, and Suresh Kumar are eminent teachers. They are well clinician and also academicians. I wish him all success in their endeavor in AMS practice. I also wish the outgoing team led by Dr. Rajesh Babu, Dr. Swami Jayaraman, and other officials. Thank you for the opportunity. Thank you. Over to Dr. Sendil.
Thank you, sir. Now I request our President-elect, Dr. Ravi Kumar sir, to give his words of felicitation.
Good afternoon, all. Respected President, leaders of state leaders, national leaders, and the participants who have taken part in this program. I am very much delighted to give this felicitation. My appreciations to the previous team, led by Dr. Rajesh Babu, a man is a bulldozing man who always conducts programs with enthusiasm. Dr. Jayaraman and Dr. Sendri, who did extremely well the last 2 years. They have made a benchmark in AMS. And the current team, no wonder, Dr. Nirmal, a man of quality, Dr. Sendil, a man of execution, and Dr. Mohammed Ibrahim, a man of perfection. A good blend of team has taken over this AMS. No wonder they will take the AMS to the next height. And I am very much glad that a very interesting topic and the topic for the time has been selected, because this being the winter season and the common infection is more common. My own classmate and a close friend of mine, Dr. Neminathan, is well known for educating the people, and I am very much happy that he has offered to give his talk today. And Suresh, we all know that he's a man of infectious diseases, perfectionist, and that right topic on the antibiotics, right usage of antibiotics. I am proud to say that recently the Indian Medical Association headquarters conducted the program of AMR, Antimicrobial Resistance Week celebration of WHO. And it was a very wonderful program organized across the country for a week. And I am proud to say that my hospital, though it is a small hospital with less than 40 beds, we can also take part in such initiations of antimicrobial resistance. And my hospital is a smart AMR smart hospital. Not only that, we conducted the program of AMR Awareness Week during the November. And we got the best awareness award, national award this year. Why I am saying this is, we always think that the small players, the clinicians, the one-man clinic, hospitals and clinics, we think that these sort of following the antibiotic protocols or following any health protocols is difficult. It is not so. Even small hospitals can do that, and we have proved that we can do that. And AMR, I'm very happy that we have a topic on that today. Congratulations, Dr. Suresh sir. We expect many things from you. And Dr. Raghunandan, he's a great man. He's a great teacher. We had a very good period when I was state secretary. He was the nodal officer for the COVID, and the COVID was rampant at that time, you all know. And he did a wonderful job, and he was very useful for us in bringing out various protocols to be followed during COVID. Congratulations, sir. I am very happy that you are part today. So best wishes to the team. We will hear from the great team about the infections and how to go about in this seasonal time. Thank you so much for giving me this opportunity. Over to Dr. Sendil.
Thank you, sir. So now I request our immediate past secretary, Dr. Karthik Prabhu sir, to give his words of wisdom. Yeah.
Thank you, Dr. Sindel sir. Sir, I'm sure this is a wonderful topic and very carefully handpicked, and I'm sure This year, your team and is going to do a great job. And best wishes to you, sir. I've just seen the topic and really looking forward to look into the meeting. Thank you. Thank you, sir. Best wishes for you.
Thank you, sir. Thanks. Sir Nirmal, sir. Amudan, sir, has come, sir.
Couldn't see him. May I invite Dr. Amudan? He is here. Okay, we'll move on, Sandra.
Yes, sir. Dr. NRT, sir. I think he has also not joined, sir. Probably he might join. So, yes, sir. So now, yes, sir. So now we will move on to the session directly. And now I request Dr. Nemanathan, sir, Coimbatore Child Trust Hospital, to start his session and also take over the evening. I request you to start the session, sir. Thank you, sir.
Thank you, Dr. Sendil. Is my slides visible? Am I audible?
Yes, visible, sir. Audible, sir.
Loud and clear.
Yeah. At the outset, I'd like to thank the President, sir, Dr. Sridhar, sir, Dr. Dirve Mohan, and Dr. Solomon and team. And my sincere thanks to Dr. Sengatuvan, sir, Dr. Ravi Kumar, Dr. NRT, Dr. Jayalal, sir, Dr. Karthik Prabhu, Dr. Gauri Shankar, and my sincere thanks to the new team of AMS headed by Dr. Nirmal and Dr. Sendil and Dr. Ibrahim. My wishes and thanks to my
size box.
please mute yourself. Please mute yourself.
All except the speaker.
I think mute all. Yeah. My sincere thanks to my co-speakers, Dr. Suresh Kumar and Dr. Raghunandan sir, for sparing time and accepting our invitation. Friends, today's topic is going to cover the crux of the matter, what is needed for the practice, both pediatric and adult, and what is going to be the future also we are going to discuss. So friends, this is going to be a very, very important topic, particularly for all the doctors in our state in relation to the current epidemics of various viral illnesses. As rightly told by our president, we are facing lots of viral outbreaks. It comes in sprouts. Various areas are affected by viruses like human coronavirus, which is a modified form of a COVID that's been circulating now. And we do have lots of influenza, para-influenza, adenovirus in some pockets, and human metapneumovirus, RSV virus in young children, and rhinovirus in infants. So from top to bottom, we've got lots of viruses that is circulating in our entire country. The two, particularly in South India, the two in Tamil Nadu. So we are going to discuss about everything in a nutshell over the next 2.5 hours. Friends, let me go to the first slide. The million-dollar question that we face in our day-to-day practice is whenever you see a person who comes to our consultation chamber, whether he comes to us with a fever, and we like to know whether the given fever is a viral fever or a bacterial illness, because it will make us to prescribe antibiotic. So that part is very, very important. Within a matter of minutes, you need to make a differential diagnosis that will help us to avoid prescribing antibiotics. Because during this season, particularly in pediatrics, vast majority, more than 90% are viral in nature, and vast majority do not require any antibiotics. Just applying this 5-point rule, you can come to a reasonable diagnosis whether this is a viral fever or a bacterial fever. Point number 1 is that a well child who gets a sudden onset of high-grade fever means that the organism that is causing fever has got ultra short incubation period. Friends, you will all agree with me what you have learned in your undergraduate curriculum. All viruses have got short incubation periods, whereas bacteria have got long incubation period. So sudden onset in a well child is, until proven otherwise, is viral in nature. At the same time, because of this ultra short incubation period, in a given time, more than 1 member or 2 member or 3 member of the family will be having fever at the same time. So history with more members in the family, or in the street, or in the colony, or in the city, or in the state, or in the country, or in the globe, is always swings the pendulum towards virus. All viruses are known for dissemination, either inside the family or inside the community. That's why most of the pandemics are caused by viruses. You have swine flu pandemic, COVID pandemic, bird flu pandemic, everything is virus. So, having said this, if on throwing a flash of light, you see the eye is red, throat is congested, nose is watery, multiple sites is involved, dissemination is there, probably it swings the pendulum towards virus. At the same time, there is a localized area where you have a suppurative node in the neck. It's bacterial suppurative lymphadenitis. Or you got a suppurative joint alone is swollen, fever, pains, bacterial septic arthritis. Only one site is involved, probably it is bacterial. Multiple sites are involved, probably it's viral. At the same time, multiple systems that is involved. If you ask the mother, என்னமா பண்ணுது, she says that, sir, suddenly fever வந்துருச்சு, வந்த உடனே அப்பவே காஃப், கோல்டு, ரன்னிங் நோஸ், டயரியா, ஸ்கின்ல உடம்புல பொறிப்பொடியா இருக்குது, வாந்தி பண்ணிட்டே இருக்கான், சாப்பிட மாட்டேங்கிறான், வயிற்று வலி இருக்குது, நைன் அழுதுகிட்டே இருக்கான், அது verbal diarrhea. So the moment she complains of lots of system involvement, or on examination you have a rolls, you have watery diarrhea, skin rash, maculopapular rash, everything sinks the pendulum towards viral infection. As I told you, viruses do not limit themselves to one system. It is called dissemination. So dissemination is hallmark of viruses, whereas bacteria localize only one side, bacterial pneumonia, bacterial dysentery, bacterial UTI, only one system, bacteria, multi-system virus. And another important point, particularly in pediatrics, is that you have to ask the mother how did the child behave between two fevers. The mother says, after giving paracetamol, within next 48 minutes, child was sitting in one place. Once the fever touched normal, he started jumping about, going, playing, not able to control him inside the house. If the child is active in between the two fevers, it's called interfebrile period. That swings the pendulum towards viral illness. Whereas in bacterial illnesses like enteric fever or pneumonia, child be dull even if the fever comes down. There'll be tissue hypoxemia. So by applying this simple 5-point rule in every patient, particularly in children who come to your chamber for a fever during this monsoon, you can reasonably come to a diagnosis that this is a short pyrexia without any localizing signs, most probably viral, without danger signs. And only thing what you need to give is you have to prescribe only paracetamol, and the co-prescription is ORS, and always send them with a counsel about the danger signs, because many of these viruses like dengue and dengue-like viruses can develop danger signs after the disappearance of fever. So every given child who comes to you with viral fever, you have to educate them that if there is any danger sign like poor feeding or irritability or reduced urination or any bleeding anywhere or cold peripheries, they have to come back immediately. Just by counseling, you can reduce the mortality of any viral fever to practically zero. You can make our country a zero mortality country, but just by spending extra 1 minute by educating about danger signs. And the most important message in this slide is that whenever you make a diagnosis of viral fever, please put black and white that it is viral fever, no antibiotics is required. And never prescribe antibiotic for a viral fever, thinking that I'm giving prophylactic antibiotics for secondary bacterial infection. Please remember, in an immunocompetent child, there is no role for antibiotics because there is no secondary bacterial infection in a healthy child in an outpatient practice who develops a bacterial infection following simple viral illnesses. From today, say no to antibiotics in viral fever. That's an important message. So having seen this, friends, please remember, fever is not ceftriaxone deficiency. Do not admit a child with fever, simple viral fever, and start on ceftriaxone. So this point is very, very important. And the commonly misused drug in outpatient is azithromycin, and inpatient it is ceftriaxone. These two drugs should never be used in our practice if you consider viral fever as an entity. So the important question that I'm going to ask you, all the participants, nearly around 800 participants have joined now. The question is, can somebody tell me which is the best multipara monitor available on earth? Friends, I'm sure you will all agree with me. Mother is the best multipara monitor available on earth. she can find out even a minute change in the pathophysiology of the child. The message is for youngsters who are attending this, never ignore her words. If the mother says, "Sir, somehow I think my child is not well," probably she is right. So don't send them back. You keep the child inside, monitor, take a proper history. There will definitely be something that is hidden or something that has not come to the surface. Probably this child will worsen matter of hours. So you have to definitely give importance to mother's words. That's very, very important. With that introduction, friends, commonly we see lots of children who come to you with pharyngitis, throat pain, dry cough, high fever. So this is a season in which entire Tamil Nadu, there's an outbreak of illnesses both in young, old and adults also. So such a situation, whenever you see a child with enlarged tonsils and follicles, your diagnosis is very simple. It is written on the face. It is group A beta hemorrhagic streptococcus that causes acute follicular tonsillitis. And the drug of choice is amoxicillin, 40 to 50 milligram per kg per day. It has to given for a period of 7 to 10 days. Not only for this infection, the main purpose of giving for 10 days is that to prevent rheumatic heart disease. That's an important message.
I think we lost the audio connectivity. Sir will join soon. Please stay with us. Dr. Neminathan will be joining soon. He had server issues. He'll be joining soon. Yeah. Sir has joined, so we'll start the proceeding soon. So you can share screen, sir. So Neminathan sir, please unmute yourself. We are able to see your screen. Sir.
Yes, sir. Yeah. Am I audible, sir?
Yes, yes, sir.
Is my slides visible? Sorry.
Yes.
Sorry,
Visible,
there
sir.
was an
Kindly
interruption in the
proceed, sir.
connection.
No problem.
Yeah. As I told you, whenever you see a child who comes to you with a throat pain, which is common at present, particularly in the months of November, December, January, February. So most of these children who do come to you with pharyngitis, throat pain, they all have a high fever, sometimes with running nose or cough. So most important thing, what you need to apply is a score called modified center score, or it's called McIsaac score. It's very, very simple. It has got 5 determinants. One is the age between 3 to 14 years. There is a pharyngitis, probably it is bacterial, 1 point is given. Fever above 100.4 or 30 degrees Celsius, one score. When there is a tonsillar exudate, it's probably one bacterial, 1 score. Tender anterior cervical adenopathy, 1 score. And the absence of cough is classical of bacterial, and a cough presence swings the pendulum towards virus. If the cough is absent, 1 score. So totally you have 5 scores. Out of which, if the child has a score less than 1, that is 0 and 1, definitely this is viral, no need for any test, no antibiotics. And if the score is more than 4 or 5, it is definitely bacterial. It is, until proven otherwise, it is a bacterial. So you can start on simple antibiotics like amoxicillin. You will not give third generation cephalosporin. A narrow spectrum, orally available, cheap is amoxicillin. So the problem comes when you have a score between 2 to 3. That's called intermediate. So in such a situations, what WHO recommends is to do a rapid CAR test, which costs around more than 500 rupees. It is not available everywhere. And then if the test is positive, take culture and give antibiotics. If the test is negative, wait on antibiotics. But many a times in our day-to-day practice, a poor patient, you cannot do this costly test. So what you can do is, wise advice is, when you have an indeterminate score between 2 to 3, you just wait for 48 hours. No harm in waiting for 48 hours. After that, if the child improves, most probably it is viral. Do not give any antibiotics. Just monitor the child, give paracetamol. What best you can do is steam inhalation or salt water gargling, or give some hot water with honey that will subside the illness, including the cough. So no treatment is required. If the child deteriorates, even after waiting for 2 to 3 days, the symptoms are worsening, then you can consider bacterial and give antibiotics. What is the rationality in starting antibiotic later after 3 days or 4 days? The message is, the ideal purpose of giving antibiotics in a streptococcal sore throat is to prevent rheumatic heart disease. So you can, the antibiotic of use, even if you start any antibiotic before 9th day of making of the onset of symptoms. So you got this gap, the dynamic treatment gap. So up to 9 days, you can start the antibiotic and the protection for rheumatic heart disease will be achieved. So sometimes you have a lab that reports this group A beta hemolytic streptococcus is resistant to amoxicillin, sensitive to some other drug, X or Y drug. In that case, please remember, this is one organism that has not developed resistance against penicillin since the time of invention of penicillin. Another one is spirochetes. So if the lab shows resistant to amoxicillin, Please change the lab, do not change the antibiotic. So this test is done to test the lab, not the patient. So many a times we see during this season, we see lots of children coming to us with conjunctivitis. Some of the children, older children say, Kannu uruthudu. They keep on rubbing their eyes. They say some gritty feeling, some sand-like thing is in the eye. They keep on rubbing. Itching is there. And some children do have periauricular adenitis. And this was one child who came to our OPD couple of months back, 6 months back. At the time, there was an outbreak of this virus. This child had URI, LRI, watery diarrhea, skin rash, and the duty pediatrician did a total count which was high. CRP also was high. Urine showed puzzles more than 10 with the conjunctivitis. So I request all these people to consider these four organisms that commonly runs in your mind. The most important message is when you have such a child with polysystem involvement, I already told you, adenovirus should come to your mind. Adenovirus is a great bacterial mimicker. Sometimes you can have puzzles in the urine, but the culture will be sterile. That's called sterile pyuria. Apart from this, in another disease, Kawasaki also, you have this sterile pyuria. So if you have a combo of conjunctivitis, LRI, URI, AGE, skin rash with sterile pyuria with elevated counts and CRP, do not prescribe antibiotics until proven otherwise. It is adenovirus. So do not give antibiotics. There is a multi-system involvement. So the message is, when you see a child with conjunctivitis, look for two things. One is a gritty feeling and itching in the eye with preauricular adenitis. These two things are there. This is pointing the finger towards viruses. So do not give antibiotics if these two are there. So the commonly misused area where antibiotic high misuse is conjunctivitis. Even eye drops will produce antibiotic resistance in the society. So never prescribe conjunctivitis eye antibiotics if there is a gritty feeling or itching or preauricular adenopathy. It's a very, very important carrier message. Please mute yourself. Dr. Vijay Ramdas, please mute yourself. This is a 6-month-old infant who was brought to us with extreme irritability. And the child was also febrile. Fever was more than 102. And the mother came because the child was not feeding, having incessant cry. And there is a history that there is no history of drug intake. And when I just gave a lateral pressure on the skin on the arm, the started developing peeling of the skin. That's a Nichols kinase was positive. So in such a child, I will request all this audience to make a diagnosis of when the febrile toxic child with a history of no drug intake, you have to consider staphylococcal scalded skin syndrome, SSSS. It's called Ritter's disease. It's an exfoliative toxin that is liberated by the staphylococcus. And many times these children can develop either high fever during the bacteremia or they can develop hypothermia and dehydration. The closest differential diagnosis is SJS, Steven-Johnson syndrome, and toxic abdominal necrolysis. Both of these have got Nichols kind positive, but there will be issue of drug intake. So, but in this child, there was no issue of drug intake. I request everyone to mute yourself. Post to mute everyone. I request the officer to mute everyone. So, when there is no issue of drug intake, staphylococcal scalded skin syndrome should come to your first in the mind. And please remember, for this simple cephalosporin like cephalexin or cefatoxil is sufficient. But the only thing is, because of this toxemia, toxicity, you need to add clindamycin, which has got antitoxic effect, antitoxin effect. So these two are important. Please remember, never give ibuprofen in such a child because you can land up with renal toxicity. If there is a fever, just give only paracetamol. Another important message is, all children with staphylococcal scalded skin syndrome do not require antibiotics. If they are not having fever, if they are not toxic, if they are stable, the child is active with the staphylococcal scalded skin syndrome, please remember, do not prescribe antibiotics because It is toxin-induced skin esquamation and it does not require antibiotics. This child, since the child was febrile, toxic, we started on antibiotics. Having seen this, let us see another child. Quite often we do see children coming to our OP with small abscesses. This child was an older child, school-going child. Above the right cubital fossa, child had a 3 centimeter abscess, and there was no signs of cellulitis. There was no systemic signs. This child did not have any comorbidities like chronic disease or immunosuppressive conditions. So in such a situation, quite often we see lots of children with abscesses. They come to your OPD. The important message is you must never misuse antibiotics here also. Vast majority of them do not require antibiotics. This child abscess was less than 5 centimeter. Just incision drainage alone is sufficient. No need for antibiotic. We ask the child to come back for review on all.
Ima sir, please unmute yourself. You need any support?
Yes. Yeah. So sorry once again. Please remember, whenever you have a child who has got less than 5 centimeters abscess, it's enough if you do IND alone. There is no need for oral or IV antibiotics. Antibiotics are indicated in an abscess when there is a severe extensive disease or the disease that is progressing to cellulitis, or there is a systemic illness like toxemia, or a child was a sick looking child with systemic symptoms, or when there is a comorbidity like coexisting disease or immunosuppression, acquired or immunosuppression due to steroids, or an abscess that is in difficult to drain sites like face or genitalia. Only these 5 conditions you are supposed to give antibiotics. Otherwise, in a routine small abscesses, do not give antibiotics. Am I audible? Is my slides visible?
Yes, sir. Visible, sir.
Yes, sir. Here you have a 7-year-old child who is active, but the parents are concerned about a fever that's been coming there for 5 days continuously. And the total count was low, 4,100. The eosinophils in the Holter, the monocytes were 0. The hematocrit and hemoglobin was normal. Child had a coated tongue, and child also had a tip spleen. And child went to Mumbai a week earlier, and child took a street food in the Mumbai. So in such a situation, what will be your line of action? I given 4 situations. The message here is, this is everything fits in directly with the enteric fever. So most important thing is, whenever you see a child with CBC showing eosinopenia, it's a surrogate marker of enteric fever. Probably you are dealing with enteric fever. A history of having street food, travel to Mumbai, and also relative bradycardia with a coated tongue, tip spleen, all swings the pendulum towards enteric. Always take a culture before you start antibiotic. And the dose of cefixime in enteric fever is 20 mg per kg weight, because this organism is intracellular. Whereas if the child has got an infection in the urine, you have to give 15 mg per kg weight. If there is an infection in the gut, cefixime is 8 mg per kg weight. So you have to scale it up according to the same drug, various doses according to the disease. And also the blood culture, the volume of blood to broth ratio is very, very important. In a neonate, you need to take around 1 ml. Older children, 2 to 4 ml. In adolescents, you need to take 10 ml. So if the blood to broth ratio should be minimum 1:5. In that case, you can definitely will get an organism that is grown in culture. The reason why many of the labs are not growing culture is because the blood collected was very less. The commonest error that we make in our day-to-day practice is medication error. Whenever you see a child, always monitor the growth, always plot the growth chart, and look at the weight of the child before you prescribe. And the drug should be written as milligram per kg per dose. And this medicine should be checked by yourself. Many a times paracetamol comes with various presentations, like drops that contains 1 ml 100 milligram, syrup that contains 5 ml 125 milligram, another syrup that contains 5 ml 250 milligram, another syrup that contains 5 ml 500 milligram. So you will write drops, but the mother would have given syrup, and you would have written syrup and the mother would have given drops. So always check the paracetamol, because the most misused antipyretic is paracetamol. Many a times this happens in our day-to-day practice. Make sure that you see every paracetamol by yourself. And we do see children coming to us, particularly school children coming with a human bite. Please remember, human bite is polymicrobial in nature. You need to give amoxicillin to prevent spreading cellulitis. And there is no need for ARV, anti-rabies vaccine in a human bite, because it doesn't spread through human bites. And the organisms are nearly 50 in number. It has both aerobes, anaerobes, gram-positive, gram-negative. All organisms are there. The commonest organism is notorious, that's called Echinocordans. that causes spreading cellulitis. This was a child whom we saw a couple of weeks back. The child received DPT 5 years dose and went back home. Within half an hour, child came back with a big swelling on the left upper arm. So the child received the vaccine. The child was due to get the vaccine at 5 years of age. The child failed to come at 5 years of age. They came at 7 years of age. Because at 7 years we give in the deltoid, less than 7 years we give in the anterolateral mid-thigh. This child developed a big swelling within a matter of hours. So the message is, whenever you see such a swelling, rapid increase in the swelling of the hand, when we check the hand, it was nearly 3 times that size of the normal hand. Sudden big swelling. The parents were worried. So whenever there is an hyperacute activity that happens to the body, whether it is a swelling or a pain or something, it is always immunological. It is not infection. Infection will take hours or days, whereas immunological is very, very hyperacute. So this reaction is called Adas reaction. It's a type 3 hypersensitivity reaction. It is due to antigen-antibody complex mediated vasculitis, particularly occurs with relation to diphtheria, pertussis, tetanus, toxoid vaccines. Most of the time, they are all local in nature. They do not require antibiotics. This child, we told them this is a simple reaction. It will settle down within 24 hours. We reassured them. We showed them the photograph in the textbook of Nelson's textbook of medicine. They were happy and they came back on the next day with a normal hand. So nothing is required. Even no drugs is required. Whereas some children develop systemic symptoms. That's called serum sickness. It will occur only later, after 6 to 15 days. Those children need treatment. Whereas if it is hyperacute reaction following DPT, it is type 3 hypersensitivity reaction. If you have knowledge, you can save your practice. So since we immediately informed them that this is nothing to worry, the parents were happy. The child also did not receive any medicine, became all right without any treatment. Sometimes we do see children coming to you with a stool microscopy showing lots of ES cysts, and the lab technician would have underlined ES cyst. Please remember, entamoeba histolytica cyst is common finding in anybody's stools, even a normal healthy person. All the doctors, 1,000 doctors who are attending the CME, if we do stool culture for all of you, cyst will be there. So nothing to do. Cyst is non-pathogenic. It is petrophagoid that pathogenic. In this child, no treatment is required. No metronidazole, nothing is required. So most important message is, whenever you see a lab report, you must know to interpret it properly. And many of these lab reports which are underlined in red are require only to ignore, and you need not unnecessarily treat the patient. Sometimes they do come with a lab report called Vidal positive 1 in 40 or Vidal positive 1 in 80. Underline is written. Please remember, for a Vidal to be positive, at least O and H should be more than 160. Both O more than 160, H more than 160. Another important point is, Vidal test is an outdated test. Do not do Vidal for your routine patients, because nowadays we don't do Vidal at all. So no standard textbook mentions to do Vidal for enteric fever. So do not do Vidal. So this is another child, school-going child, who had 8 days of fever and 3 days of chest pain. On examination, child was really tachypneic. Respiratory was nearly around more than 50. And there was a left basal cryptation. Of course, there was some bronchial breath sound. Child also had a mucopapillary rash, some oral involvement also, with a redness of eye. And the child came back in the same night after 4 hours after seeing the OP. In the midnight, they came with a blurring of vision. On CBC was done, which showed 7 grams. This child, whose hemoglobin was 13 grams 1 month back, so now it has become 7 grams. There was an increased retic count. Direct Coombs test was positive. Total count was 22,700, polys 86, polymorphic leukocytosis. The child was admitted and started on ceftriaxone on oxygen. Blood culture after 3rd day did not grow anything. And the child did not improve even with adequate therapy with ceftriaxone. Child also had a left lower lobe pneumonia. So this child did not respond to ceftriaxone. The reason is that most of these organisms that do not respond to ceftriaxone means they are all atypical organisms. They do not contain cell wall. Ceftriaxone or any penicillin acts only when there is an organism with cell wall. So this child had a pneumonia, exanthem and enanthem, mycoplasma-induced rash and mucositis. This child had a severe hemolytic anemia, that is Coombs positive. Child also had arthritis, AGE, conjunctivitis, iritis, causing blindness of vision. With a single dose of azithromycin, the vision regain. Sometimes these children can develop myocarditis or pericarditis. Rarely, some of them even develop hepatitis with elevated SGOT and PT. The most important message in mycoplasma is this: multisystem involvement with skin and other organs. In the absence of coryza, they do not have coryza, please remember. And cutaneous manifestations is a protein manifestation of a mycoplasma. The drug of choice is azithromycin 10 mg on day 1, followed by 5 mg on next 4 days. Rarely you do get azithromycin because of misuse of azithromycin. For such cases, you can use doxycycline. So sometimes you do see children who come to you with watery diarrhea. This child had a watery diarrhea, skin rash and a dry cough. Child also had a URI, watery nose. And the first pediatrician who saw the child prescribed zinc and ORS, reassured the parents, sent the child home. As the diarrhea did not settle down, they went to another practitioner in order to satisfy the patients. The prescription was given as lopramide. Diarrhea stopped immediately. Parents were happy. But 2 days later, the child started having abdominal distension. They reported to another institution where they diagnosed paralytic ileus, and it was drug-induced paralytic ileus. So never try to satisfy parents by giving drugs to reduce the symptoms. Always treat the underlying disease. So when there is a multi-system involvement with watery diarrhea, probably you are dealing with a viral illness, and there is no need for any drug to treat this watery diarrhea. Only drug that is recommended by WHO is zinc and ORS. An anti-motility drug should never be prescribed in pediatrics because they can cause dreaded complications like paralytic ileus and toxic megacolon. And please remember what you have studied in your undergraduate curriculum. Whenever there is a watery diarrhea, the pathology is in the small gut. Probably it is viral. Most majority of them are rotavirus. Just maintain the hydration by ORS and giving continuing breastfeeding. And there is a mucoid diarrhea with blood and mucus. Probably it is large gut pathology. It is called dysentery. Most of the time it's caused by bacteria like Shigella or an E. coli. Rarely due to some Giardia and other parasites. So vast majority of the bacterial dysentery are caused by bacteria with the pathology in the large gut. So you have to prescribe antibiotics only when there is a dysentery, large gut involvement. Another area which we need to focus apart from antibiotics is unnecessary ordering X-rays. Please remember, when a child has got it, the pathology is in the luminal pathology. So it is because of the stimulation of the respiratory cough receptors in the bronchial lumen, in the pharynx or oropharynx or larynx. So X-ray does not bring out any relevant features in an X-ray chest with a luminal pathology. So whenever you suspect a pneumonia, when there is a grunting or tachypnea with fever, or there is a bronchial breath sound, you suspect pneumonia, take X-ray chest. Or when there is a sudden onset of cough in a well child, you suspect foreign body, take an X-ray chest to see for atelectasis or localized emphysema, obstructive emphysema. Otherwise, do not take X-ray chest for a routine simple cough or any wheezing child. So wheezes are all triggered by viruses which does not require X-ray chest. Please remember these 2 points. Another important message for practitioners is that during this viral fever season, most of these children come with fever and a cough. Avoid cough syrup in children less than 2 years of age. As per Nelson's textbook of medicine, And do not give any cough syrup that contains multiple drugs inside. That's called polypharmacy. Many cough syrups contains bronchodilator, antihistamine, decongestant, mucolytic, cough suppressant, all having opposite action put in a single bottle. Nothing will act. So always use a monopharmacy, single ingredient cough syrup. Please remember, when a young child has got a common cold, stuffy nose, sleep disturbance, you can use first generation antihistamine, that is diphenhydramine, because this crosses blood-brain barrier. It will not only give relief to the cold and also sleep to the child. In isolated dry cough, particularly in children who have undergone a surgery where the suture can pop out, you can use dextromethorphan at the dose of 1 mg per kg weight. If the child has got allergic rhinitis or a postnasal drip, please mute yourself. If the child has got allergic rhinitis or postnasal drip in a child who is going to school going child, particularly child gets a cough, as soon as the child goes to bed, it's probably because of postnasal dribbling. So these children require second generation antihistamine like fexofenadine, levocetirizine or desloratadine, because these drugs do not cross the blood-brain barrier, does not cause scholastic performance involvement. And if the child has got chronic cough, a dry cough in nature, particularly in the night after 12 o'clock, early morning 5 o'clock, without fever, with a history of atopy or an eczema, or with a history of family history, with a history of having cough that appears after exercise or during monsoon or after a particular food, probably this is hyperactive airway disease. You need to give short-acting beta-2 agonists. And the safest antitussive that you can give in your day-to-day practice for all children above the age of 1 year is honey. It has got a good demulcent effect, antitoxin effect. It has got increased cytokine release that reduces the need for use of other drugs. And also it has got the safest excellent safety profile. It is recommended by WHO, Nelson, and also pediatric clinics of North America. The dose is 2.5 to 5 ml, either BD or TDS or HS with warm water, little warm water. Should not be used for children less than 1 year because of the fear of botulism. Always try to use standard honeys that is pasteurized in nature. And whenever you have a short Pyrex illness in a well-looking child, just monitor the child, counsel about danger signs. Just adequate, tell them about the hydration, tell them about the need for review. Whereas in a febrile child, ill-looking, sick child with a red flag sign, it's treated as an emergency. And in pediatrics, you have to be very cautious in 4 situations. Number 1, any febrile neonate that comes to you, there is a high risk of serious bacterial infection to the tune of around nearly more than 20%. So always do a sepsis screen. Do not hesitate to start on antibiotics if you are in doubt. If the screen is negative, you can stop antibiotics. In children less than 3 months of age, occult infections are common. To the tune of 12% is serious bacterial infection. For occult infections like occult UTI, you do a urine microscopy. For occult pneumonia, you need to take an X-ray chest. And for occult bacteremia, if you suspect bacteremia, you do a total count. There may be elevated total count. So before you start antibiotic, take culture and start an antibiotic. In children who are immunocompromised with a chronic disease of the heart or the kidney or the liver or the brain, or if they have got comorbidities like immunosuppressed state, cured or on steroids, you need to give very cautious because they are prone for secondary bacterial infection even in viral illnesses. So when there is an outbreak, you have to be very, very cautious. So these are the 5 situations in which in pediatrics you have to be very cautious. You have to use antibiotics upfront. These are the important red flag signs whenever you see a child in your outpatient practice. In gram-negative infections in young children, you can develop hypothermia rather than a fever. And fever is also, if it is more than 30 degrees Celsius, you have to be very cautious. Any child who has got poor feeding or breathing difficulty or feeding difficulty with reduced urination, with excessive irritability in young children or older children complaining of lethargy, with apnea, cyanosis or bulging fontanelles, with a shock as revealed by a cold periphery or increased CRT, with mottling, These are all red flag signs. Even with a simple fever or even in absence of fever, you need to treat them, because many viruses like dengue virus, the danger signs appear after the disappearance of fever. Please keep this in the back of the mind. And very important carry-home messages, last 3 slides. Do not treat the fever. Fever is a manifestation of an underlying disease. Always treat the cause of fever. Use only paracetamol. Do not use any other antibiotic other than paracetamol. Do not do CBC on day 1. Your CBC on day 1 will give you false sense of reassurance. Whatever the disease, whether it is dengue or any other illness, on day 1, CBC will be nearly normal. Only after 2nd day, by 3rd day, you will start seeing changes in the CBC. Counseling is very, very important. You have to tell them insist on daily review, preferably BD review, and tell them that if the danger signs are there, they have to come back even in the absence of fever. The best co-prescription is ORS for young children 50 ml per hour, older children 100 ml per hour. A simple tool in the management is to manage the child's urine output. Bare minimum of 0.5 ml per kg per hour is mandatory. For example, a 10 kilo child should pass 30 ml every 6 hours. And abdominal pain is an early sign of a plasma leakage, particularly in dengue. If any child who complains of abdominal pain on 3rd day after the disappearance of fever, please make the child lie down, put your hand on the liver, see for tender hepatomegaly or early evidence of ascites. In that case, keep the child inside short on IV fluids. That's the earliest evidence of a plasma leakage. Never give steroids. Never give IM injections. Never give NSAIDs, particularly in febrile viral illnesses, because of fear of Reye syndrome. Never give antibiotics in viral illness. Never tell the patient not to give self-medication or do a self-test. Sometimes you do see mixed infection in your practice. We have seen during COVID period, COVID and dengue. During dengue seasons, we had dengue with leptospirosis, scrub typhus. Even now, we have got a child with influenza with a bacterial pneumonia. So IV fluids in dengue has got narrow therapeutic index. Use it only for 48 to 72 hours. If you misuse, if you overuse, you will land up in iatrogenic pulmonary edema. Always admit these children. Do not treat them in your clinic, because if you give IV fluids BD morning and evening, it will lead on to compartment syndrome. Mortality will be high. If you don't admit a child with dengue and give continuous IV fluids, because in dengue, there is a continuous loss of fluid from the intravascular compartment to the extravascular compartment. And if you give IV fluids when you are clinic in the morning and evening, during the time between when fluids are not given, they will go in for shock and leak. So it will lead on to mortality. So always admit these children. Do not treat them as outpatient in your clinic. And avoid commercial drinks like aerated drinks, particularly in dengue, because they lead on to, the sugar level is very high. They will lead on to fluid related complications. And dengue is not a platelet disease. From today, forget platelets and focus on patient. In dengue, patient can walk with shock. That's very, very important. Always monitor the children's hourly if they are in inpatient, because a simple dengue can become severe dengue. Always do a CCTV. Always remember your hospital CCTV. Add R to that. Color of the child. See for there is cold extremities. Look for the temperature, pulse volume, and respiratory rate. CCTV. If you can do this, it takes less than 30 seconds. You ask your receptionist to do this. If any child has got any changes in this, if they are brought to you inside your OP room, you can identify them early, treat them early, so that the mortality, morbidity will be grossly reduced. And prompt referral always saves these children. Coming to the golden rules in pediatrics, parents are your partners. They are not obstacles. Please mute yourself. Parents are always your partners. And children deteriorate faster than adults. Reassess repeatedly. When you have doubt, observe them, reassess them, escalate the treatment immediately. That's very, very important. Never send them back when you have doubt. So CBC is a very important tool. As I told you, in dengue, there will be a sudden increase in the hematocrit. More than the platelet, hematocrit is very, very important. In enteric fever, there will be eosinopenia. In malaria, hemoglobin will be low. There will be eosinophil count that is high. That is called monocytosis. So Last slide. In pediatrics, antibiotics, particularly during this season, more than 90% do not require antibiotic. More than 90%. Of the less than 9% that require antibiotic, only 3 antibiotics are enough. If the child has got supradiaphragmatic infection, it is caused by gram-positive organisms. Your drug of choice should be amoxicillin. In infradiaphragmatic infection, which is caused by gram-negative organisms, the drug of choice is cefixime. In skin and soft tissue infection, first generation cephalosporin like cephalexin or cephalroxil. Only 3 antibiotics in your pediatric practice. With that, let me thank you all. If you got any doubts, you can post it in the chat box. My number is there, 984221179. If you want these slides, please send a request to me by WhatsApp, 984221179. You can note down this number, take a screenshot of this slide. So friends, I request my co-speaker, my close friend, Dr. Suresh Kumar, who is an ID specialist, a renowned national ID specialist from Apollo Hospital, to give his next lecture on the importance of antibiotics, particularly on the use and misuse in our day-to-day practice. And followed by my close friend, Dr. Raghunandan sir, will be talking about emerging, re-emerging infections. So over to Dr. Suresh Kumar. Thank you, Dr. Suresh Kumar. Suresh,
yes,
now you can.
Can you hear me now?
Yeah, you are audible. Your slides are visible.
Correct, sir. Thank you, sir. I sincerely thank Dr. Neminathan sir for giving the fine introductions, and I thank Dr. Senthil Kumar sir and AMS team for giving this wonderful opportunity. So already my job is made simple because what Dr. Neminathan sir has discussed about the pediatrics, we are going to apply for the adult practices also there. Usually major principles are same, but minor modifications can happen. So I'm going to discuss about right antibiotic, right patients, right dose, and right durations. This is all called 4 R's of the antibiotic practices. 4R. Usually people know 3R movies, everybody know. This is right patients, right disease, and right antibiotic, right dose, and right durations. So before that, my disclosures, 1 second, let's try to start moving. Yeah. So ID doctors won't make big money because we try to provide the solutions for the problems created by other people. So we are just providing the solutions. People are providing solutions, they're not making big money. People are creating problems, people are putting implants, people are doing some procedures, creating infection, they are making big money. But people like us, we are solving the problem, we don't make big money. I'll straight away begin with the case before my presentations. I've shown here a lot of interactions needed. People are loading with your data for your certifications, but real certifications can happen only if you start answering in the chat box whatever things we are putting so that you can get a real certificate. Instead of putting your name and registration number and paying money is not a certificate. You need to show your knowledge, what you're gaining here so that you can get a real certificate from these presentations. So next 40-45 minutes, you need to sit in front of your monitor. Whatever questions we are putting it, please put in the chat box. Show you are attending and showing your knowledge also to get the certificate. That's more important for you. I've shown here 4 patients here. Which patient needs antibiotic in your practice? For example, a 62-year-old female. She's a diabetic. Her HbA1c was 10.2%. During cultures grew 10 to the power of 5 colony E. coli. That is ESBL. I'll come back to the ESBL. ESBL means nothing. The carbapenems, the ceftriaxone, 3rd generation cephalosporins will not work. Like cefixime, ceftriaxone, cefotaxime will not work. That is called ESBL, extended spectrum beta-lactamase. The second case is a 24-year-old male, recent travel and gathering, fever, headache, and sore throat of 4 days durations. Whether does this patient needs antibiotic? Third thing, 36-year-old female, hypothyroid, diarrhea 4 times, watery, no vomiting, no fever. 60-year-old male is the first case, diabetic, long-standing, non-healing ulcers in the plantar side of the wound, and the wound swab is growing E. coli, coagulase negative staphylococci, and pseudomonas. I'm just going to see your chat box, how many people are getting the attendance today for your certifications. I just checked. So people say 4th case is needed. So 1 and 4 is needed, 4 is needed. So wound swab, they are giving more importance, and people say diabetic, poorly controlled diabetic needs. So I think people are answering, they definitely get the certificate of participations. Don't worry about it. Keep listening so you can learn your antibiotic selections. Unfortunately, these things were not taught in your undergraduations or post-graduations. That is a big challenge we are facing in the curriculum. So my objective is why this RRR. I told what are the RRR. Right patients, right antibiotic, right dose, right duration. That is my objective. When we see a patient, whether this patient needs antibiotic or not, if needed, what antibiotic to start, if want to start, what dose I need to start, what durations I need to treat. If you know the 4 R's, it's easy for you to tackle any antibiotics. I'm going to show a couple of common scenarios what they're going to face in our OPD settings as well as IPD settings also. And summary and way forward, I'm going to give you. I'll simplify your content to you people. So the case what I shown here, the second case, 24-year-old male, fever, headache, sore throat, 4 days. People not opted this choice. But if you see in the real practice, what ID doctors we do call OP prescriptions audit. Whenever you write some antibiotic prescriptions or whenever you're giving a treatment to the patients, and the prescriptions comes to the thing, my clinical pharmacist will do the audit. But here in the clinical meeting or in the Zoom meeting, people say I don't give antibiotics. If I do antibiotic of your prescriptions, definitely out of 100 prescriptions, 80% of the people or 70% of the people could have given antibiotics. We have seen during the COVID time. Initial for a couple of months, doxycycline, azithromycin is a treatment of choice. But afterwards, Government of India in June 2020, they removed it. March, April, we do not know how to treat. May up to we are treating with a lot of antibiotics and other medications. 2020 June, I remember the first guidelines came, azithromycin has got no role. But unfortunately, till COVID is entered till 2023, people are using azithromycin and doxycycline. Why? They're not attending. That is why the AMS and CGPs keep on coming in with common topics for you to choose your practice. This is not the knowledge. This is a practice-oriented session. That's what we are doing. If I do the antibiotic audit of your prescriptions of this case, I'm sure 70% to 80% of the people would have prescribed some antibiotic. But here, if people say start symptomatically, I just want to go back and check your chat column. How many say symptomatically? People who say symptomatically, we need to really do some audit for this practices. People say one, symptomatic treatment, symptomatic treatment. This is a Zoom answer for me. Unless you show your prescription solid, it's a bit difficult for me to believe what you're answering here. That is bias here. This is a bias in the meeting. But if you go to the practice, if people want to write some antibiotic, this is the statistics. 70% of the patients getting antibiotic each day. 30 to 60% of your prescriptions are inappropriate. Why the session AMS is arranging today? This is a basic reason. Unnecessary antibiotic. If you see our Prime Minister is talking about, last Mann Ki Baat is talking about the antibiotic resistance and usage of antibiotics. So this is a status of that we are living. The Prime Minister of a country speaking about the big problem bigger than pandemic of COVID. So people say, what is a big deal when I use antibiotic? What I'm going to lose? If you see, this is a publications I produced a couple of years back, not couple of years back. In fact, a decade back, 2015. See the last column, not last column, last row. If you see meropenem, in 2003, what is the sensitivity of meropenem? 99% it is sensitive. So when a patient comes to your hospital very sick, you are thinking the person has got some gram-negative sepsis. For example, urinary tract infections, severe sepsis, septic shock. What I do till 2008, 2009, if I give meropenem, that E. coli Klebsiella will work. The patient will improve, go back home. What happened in 2013? See the sensitivity, it is dropped from 99% to 50%. What it indicates, the person has got meropenem will not work. So meropenem will not work for E. coli and Klebsiella from 2009 onwards. That is a time one of the big bacteria called New Delhi metallo-beta-lactamase, NDM1, came into Indian market. So people thinking meropenem is a powerful antibiotic, but from 2009 onwards, meropenem is not a powerful antibiotic. What does this mean? Somebody calling from emergency. The patient is sick, shocky. Before 2009, I used to pick up the phone and say, give 1 dose of meropenem to take care of gram-negative and give 1 dose of vancomycin to take care of gram-positive. I'll come and see patients tomorrow morning and sort out the patients. In fact, my daughter used to pick up the phone, Mero 1 gram, Vanco 1 gram, keep the phone down. But in 2013 or 2009 onwards, this is not working. I need to dig the history, whether the person exposed to antibiotic, whether the person is sick enough, whether he needs something more compared to the meropenem. So antibiotics are not working in India, particularly for gram-negative antibiotic. The resistance is a huge problem. Unfortunately, this has not gone into the individual practitioner level. The next question people ask, okay, you are saying I'm abusing antibiotic, fine. You are saying the resistance rate is gone up, that is also fine. What is the end result? You can ask me there, what is the end result? So this is the end result. See the last column here. Patients is not gone home. The person developed resistant organisms. This is one of the best tertiary care hospital. Almost all the facility what is available in US is available to me. Almost all the specialists are available at the point of care. Infectious disease, ICU, MRI, PET, all the things is available. Despite all the specialists, despite all the facility, what is the last column? Expired, 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 expired. When the person got a resistance organism, despite good facility, specialist, whatever interventions, the patient is not going back home. This is a big problem. Antibiotic resistance is a real killer. We are seeing in front of our eyes. People say, I am not seeing, but I am seeing. Whatever antibiotic you are prescribing in OP, when the person got sick infections or severe infections, come to a tertiary care hospitals, got admitted, the chances of death is very high because there is no antibiotic. That is why the AMS session is arranged. So first, initial couple of minutes, I want to focus why this session is arranged for you. How significant is the problem? Why Prime Minister is talking in Man Ki Baat? Why antibiotic resistance is a topic for him compared to all other things? Why he is talking on antibiotics? That is why I am discussing here. Antibiotic resistance is a real problem. It's a real killer. People are losing their life because of antibiotic resistance. Compared to people lost their life because of the COVID, the number of life lost due to the antibiotic resistance is a huge one. Why this is happening? I told clearly itself. One is a peer pressure. For example, people think I don't want to lose anything. I'm a busy practitioner. So I'm seeing 100 cases in my OP. I don't want to miss something. I want to start immediately something so that I can need to cover it. That is the reason, because I'm missing something, because I'm examining the patients hardly 1 minute, 2 minutes. I'm making a decisions. 100 patients, the doctor is seeing. For me, it's not a good doctor. If you go to the US, they say the busy day. I asked the persons, because when I was rounding in US, I asked the busy day. They said, I have a very busy day today. How many patients you have seen today there? They say 6 or 7. 6 or 7 itself is a busy day for a US doctor. They need to document, I know, but despite documentations, they are spending too much because we need to spend sufficient time. Here, because of the less time we are spending, to compensate it, we are giving antibiotics. Second thing, particularly pediatricians, they know the problem. I do pediatrics also. Pediatricians, parents pressure. And the fever crosses more than 3-4 days. If you say whatever symptomatic, my previous speaker told, but they say, doctor, you are not giving antibiotics. The knowledge is so much wide because of the WhatsApp University and Facebook University. People know I want to start antibiotics. And most important thing, lack of knowledge or lack of educations. During our undergraduations, during our post-graduations, during my undergraduations, post-graduations, or during my assistant professorship training in Stanley Medical College, we never taught antibiotics, how to choose, how to select, what is the rationale behind it. Some prescription given by the chief, we are just copying it. Some prescription given by the senior persons, we are copying it. We do not know what is the importance of it. That's the problem we are facing. There is no educations. We need to know how to diagnose mitral stenosis, how to diagnose a stroke, whether it's a stroke at the cortical level or cara radiata. We need to know the thing, the corona radiata, we need to find out. But we do not know how to choose the antibiotic. That is a big problem we are facing. So why? And similarly, infectious disease doc. Infectious disease docs is not available everywhere. Fortunately, Chennai, Coimbatore, Vellore has got facility for infectious disease docs. Other places, there is no ID docs. That's a big problem. That is a big problem. So people want to use the services and other thing. That is why we are discussing today to make yourself how to choose the right antibiotic. So coming back to the first case here, some of the people voted this case. This patient needs antibiotic. 62-year-old female, diabetic, HbA1c of 10.2. This is a master health checkup. I do not know why master health checkup they included urine culture. That is why if you do unnecessary tests, we are going to treat the patients. The first teaching in infectious diseases is teach the patient, not the paper. For example, the urine culture is growing some organisms. Come back to the patient, see whether the patient has got really UTI. Where is the symptoms of UTI here? No fever, no abdominal pain, no dysuria, no urgency, no hematuria, no increased frequency. All symptoms of UTI, no. When a person has got no symptoms, presence of bacteria, more than 1 lakh colony count, that is called asymptomatic bacteriuria. Asymptomatic bacteria does not need treatment. Only 2 situations you can treat. One, when the person is pregnant, because preterm pregnancy is more common, chances of abortions is very high. So we need to treat, and pyelonephritis complications also high. Data shows pregnant women with asymptomatic bacteria, chances of pyelonephritis or preterm labor is very high. The second thing, when to treat, when a patient has got urological procedures, I need to treat. When a person is going for some cystoscopy, some procedures to the kidney, it can push us infection to the kidney. So I need to treat, otherwise I don't treat it. So the diagnosis is asymptomatic bacteria. There is no need for antibiotics. So make a diagnosis first. Antibiotic is not the first thing. Making a diagnosis is most important thing. I'll teach you how to make the diagnosis. People always think urine culture, they want to see the urine culture report. What are all the antibiotics working? What are all the antibiotics not working? This is the most important step in antibiotic selection. There are 4 steps. First thing, whether the patient needs antibiotic or not. For that, we need to write the diagnosis. Unless you need the diagnosis, it's very difficult for you. Write the diagnosis. Once you started antibiotic, daily you need to ask whether this patient needs antibiotic or not, whether my dose is correct or not, my duration is correct or not. We need to think about it. So that is called, does this patient need antibiotic? That is the bottom line. How to decide? We need to think 3 parameters to choose antibiotic. One is the host. For example, what sort of host? When a patient is neutropenic, when the person is elderly, you can't expect fever will present all cases. But other symptoms of UTI is also missing. For example, fever is not there, I don't mind. But the person does not have dysuria, hematuria, burning sensation, nothing is there. Walking, talking patients, there is no need to start antibiotic unless the person is pregnant or unless the person go for urological procedures. Previously, renal transplant we used to treat, but nowadays renal transplant also only 1 month. Previously, newborn we treat, but newborns also does not require antibiotic presence of culture growing E. coli. So we need to know what sort of the host. For example, Napoleon has lost the war not because he knows his enemy, he knows his weapon, but unfortunately he does not know where he go and fight. That is the reason Napoleon lost the war. Choosing an antibiotic is equal to going to the war. We need to know 3 things: where you are going to fight or what host you are going to treat. Second thing, what weapon you are going to use, antibiotic. Who is your enemy? That's a bug. Unless you know these things, do not start antibiotic. That is most important. Always think about the host. For example, when we can relax on antibiotic. For example, when the patient is in shock, when the patient is in ICU, requiring vasopressors like noradrenaline, dopamine. If I think the person has got infection, but I'm not able to prove the infections, I got strong suspicion of infection, at least you are justified to give antibiotic for 24 to 48 hours. Why? In the presence of shock, particularly the person has got septic shock, if you are not start antibiotic, the chances of death is very high. Second thing, neutropenia. Neutropenia is a real killer. There is no immunity to protect you there. So neutropenic host, I can't take chance. Elderly, I told the presentation is atypical. Similarly, newborn, the history taking is a bit difficult for you. Suspected meningitis. Meningitis is a real killer. Necrotizing fasciitis is a real killer. These are all called red flag signs. For this also, you need to know diagnosis. Whether necrotizing fasciitis, meningitis, elderly male with sepsis, neutropenic fever, shock, septic shock. We need to write the diagnosis. Unless you need to write the diagnosis, never think about it. These are all some exceptions. You can start antibiotic, but you need to justifications here too. Then comes before that we need to stabilize. Before starting the antibiotic, give oxygen support, give fluids, stabilize the patient. That is more important. Then how to write the diagnosis? We can't write the exact diagnosis. We need to behave like a sexually transmitted disease physicians, venereologist. Venereologist will never say syphilis. Venereologist will never say gonorrhea. Venereologist will never say chancroid. They will say genital ulcer, genital discharge, genital swelling. So we need to make a syndromic diagnosis. Syndromic diagnosis is nothing but combinations of the symptoms and signs. For example, fever, sore throat, hoarseness of the voice, either pharyngitis or pharyngolaryngitis or tonsillitis. So this is a diagnosis. Fever, running nose, sneeze, headache, facial swelling or puffiness, sinusitis or rhinitis or rhinosinusitis. Patient has got diarrhea, abdominal pain, vomiting, acute gastroenteritis. Particularly, the person has got blood in the stool, this is called dysentery. Person has got only watery stools, this is called diarrhea. Diarrhea, most of the time, there is no need for antibiotic. Dysentery, yes, needed antibiotic. Frequency, urgency, dysuria, hematuria, think of UTI. Once the person has got fever, most likely upper UTI, pyelonephritis. There is no fever, but hematuria is present, urgency is present, frequency is increased. Think about lower UTI, particularly cystitis or urethritis is possible. Not urethritis, is called urethritis. Fever, redness, swelling, cellulitis. So combine the symptoms, combine the signs, make a diagnosis that is called syndromic diagnosis. Most important thing for your diagnosis. So the first step in antibiotic, the right patient is, we need to write the diagnosis. The person with infections only, we need to start antibiotic. Particularly the person with bacterial infections only, I need to start. Infection means virus is possible, bacteria is possible, other things is also possible. So patients with the bacterial infections, I need to start an antibiotic. That is more important. Second thing is, suppose a person in a hospital, because some of the practitioners who are attending today, they got a small nursing home or hospitals or ICU. In ICU also, same thing can happen. For example, pneumonia is more common. How to make a diagnosis of pneumonia? Fever, cough, shortness of breath, chest pain. X-ray shows patch, that's fine. But X-ray patch is not equal to pneumonia. Sometimes even pulmonary embolism, pulmonary infarct, all can cause patch in the lung. So, but fever, cough, shortness of breath, yes. Absence of fever, cough, shortness of breath rules out pneumonia. Urinary tract infection, similar. When you put catheter, the chances of UTI, again symptoms, but catheterized patients is a bit difficult. Catheter per se can cause dysuria. The catheter is very difficult to assess the frequency or urgency. It's very difficult. So catheterized patients is a challenging one, but we go with some other way. I can teach you as the sessions progresses. Fever, abdominal pain, vomiting, yes, intra-abdominal sepsis. Skin and soft tissue is possible. Meningitis can happen in the hospitalized patients, particularly fever, headache, altered mental status, seizures, confusions, either because of the stroke or meningitis or meningoencephalitis. So combined symptoms and signs make a diagnosis. First thing, write the diagnosis. Without writing diagnosis, never write your treatment. So how to make a diagnosis? Take proper history. I told them what makes a good doctor versus other doctor. This is a reason. How much time you are spending with the patients. We need to take a good proper history. For example, this patient went to Coimbatore and came with the fever. That's an ordinary history. Why the patients went, when he went, how he went by travel, what he did in Coimbatore, whether he attended some gatherings or not, outside food, any sick contact, any sexual exposures. These things we need to ask. Don't say the person went to Coimbatore and came back. So elicit proper history, particularly for infectious diseases. The social background history is going to give most of the time. If you elicit sometime, that's what one of the previous speaker told. A patient went to Mumbai, taken a street foods. Why? Because proper history taking is going to help you out. Similarly, take proper history for solving the problem. Then we need to do head-to-toe examinations. I don't want a detailed CVS or CNS examination. Just examine head-to-toe, whether the person has got pallor, whether the person has got jaundice, whether the person has got some scar. Do the node examinations. We usually do cervical, axillary, and lingual region. Do auscultations. Look for murmurs, early diastolic murmur. Look for the lung, look for any bronchial breath sounds, any crackles hearing or not. So do a head-to-toe examinations. Examine the patients in detail, depending upon what you think. But minimum examinations, the person's eye should be examined, oral cavity should be examined, node both in the cervical, axilla, inguinal region, abdomen should be examined, skin should be examined. These are all must for you to make a diagnosis of it. Unless you do these things, it's very difficult to make the diagnosis. Once you combine the symptoms and signs, you can write the syndrome. So the first step here, combine the syndrome. Based upon the symptoms and signs, my diagnosis here is asymptomatic bacteria. Here, the person is not a pregnant lady, so there's no need for antibiotic. This person is not going for any urological procedures, no need for antibiotic. This person is not a renal transplant in first 1 month, does not require antibiotic. So the correct choice is no antibiotics is the correct choice. Don't repeat the cultures, don't repeat any ultrasound, don't start amikacin. Im is the answer. Yes, what we need to do, asymptomatic bacteria does not require antibiotic in these situations. Write the diagnosis. For you, the simple thing, how to decide whether the person has got asymptomatic bacteria, one score is called bladder score. We need to write, before write an antibiotic, you need to write a score called bladder score. What is bladder score? B stands for blood in the urine. L stands for loss of urinary control or loss of continence. A stands for abdominal pain, particularly lower abdominal pain. In bladder, there are two dysuria. So dysuria means, I think Prashant came, please can you mute yourself? So abdominal pain, dysuria, elevated temperatures, and patient has got repeated urine or frequency of urinations. So these are all the score. Each score has got 1 point. Dysuria has got 2 points. Why there are 2D? Out of score of 7, if the patient has got 4, the chances of UTI may not. You don't say patient has got 4, I want to think UTI. But absence of score 0, 1, 2, the chances of UTI is unlikely. So you can stop antibiotics. You don't want any further testing. So simple score, nothing else. So whenever you make a diagnosis of UTI, please always write your bladder score. What is bladder score? Blood in urine, loss of urinary continence, abdominal pain, dysuria, elevated temperatures or fever, repeated urinations. Put a score. One of the previous score, my previous speaker has talked about it. This is one of the score for urinary tract infections, particularly for a patient with the community without urinary catheter. Hospitalized patients, this is a big challenging for you. So this is how we make the diagnosis. How to make the diagnosis? Absence of the symptoms and signs rules out. Presence of the symptoms and signs cannot say. Keep in mind. So this case, how to write the syndrome? Patient says symptomatic therapy. Yes, symptomatic therapy. Before that, what is the diagnosis? Patient has got fever. Patient has got headache. Patient has got cough and sore throat. So the diagnosis is either pharyngitis or pharyngotonsillitis. He clearly told about the CENTA score. What are all the 4 points? Presence of cough, fever, viral infections. Similarly, purulent tonsil, purulent throat. A person has got tender node, fever more than 101. So these things will make patient has got bacterial versus viral infection also possible. But before that, the diagnosis is presence of fever, cough, sore throat indicate the person has got pharyngitis or pharyngotonsillitis. Then we need to think about second part. So first thing is the host part. I clearly told what are all the hosts. You can think your threshold to start antibiotic little low. Second part is the bug. This is again unfortunate. This is not taught in our microbiology. The couple of bacteria only want to remember for a practical purposes. One is called gram positive, other is called gram negative. Rarely we can come across atypical organisms. So gram positive, where it happened. The thumb rule, any infections above the diaphragm, think of gram positive. For example, meningitis, we need to cover gram positive. If it is a pharyngitis or pharyngotonsillitis, usually virus, but bacteria also can cause group A beta hemolytic strep. Similarly, pneumonia, otitis media, sinusitis. Usually sinusitis and pharyngitis is virus, but if it is bacteria, gram-positive bacteria is more likely. Similarly, pneumonia, endocarditis. So most of the infections above the diaphragm, the common organism is gram-positive. Most of the infections below the diaphragm, for example, UTI, example, intra-abdominal sepsis, think of gram-negative. If it is below the diaphragm, we need to think anaerobic organisms may not. Skin, again, skin and soft tissue, gram-positive. Bone, osteomyelitis, gram-positive. Even though above diaphragm, below diaphragm, it is a skin and soft tissue, most likely gram-positive organism. This is a thumb rule. It's not 100% sensory, 100% specific. 80% to 85% of the time, it is working well for you. So think of gram-positive and gram-negative. For example, if you think the person has got staphylococci, only the 3 organisms we need to remember in the gram-positive. One is staph. Second thing is staph. 3 is enterococci. Staph commonly present in the skin, commonly present, it can cause some pneumonia, it can cause endocarditis, it can cause meningitis. Streptococci, mostly skin and soft tissue, it can cause pneumonia also, streptococcal pneumonia. And similarly, endocarditis, particularly non-streptococcal pneumonia species can cause endocarditis. Meningitis is possible. So staph and strep almost spectrum is similar. It can affect your brain, it can affect your lung, it can affect your throat, it can affect your skin and soft tissue. Enterococci mostly present in the abdomen, even though one exception. I told them below diaphragm always gram negative, but enterococci is 1 gram positive. It can affect UTI, it can cause some cholangitis, cholecystitis because it is present in the abdomen. So this is an exception. Similarly, gram negative, we need to remember E. coli, Klebsiella proteus. Usually urinary tract infections, rarely cholangitis, cholecystitis, they can happen. This rule apply only for a community acquired sepsis. When a person hospitalized, his skin, his throat, his urinary tract may be colonized with gram negative is possible. So we need to remember what are all the organisms gram positive is possible: meningitis, skin and soft tissue, osteomyelitis, sinusitis, pharyngitis, pneumonia, endocarditis. Yes. What are all the organisms? I need to think about gram negative, urinary tract infections, intra-abdominal sepsis, think of gram negative. So whether gram negative bacteria, again UTI, gastroenteritis, these things we need to remember. Some of the community organisms like typhoid also gram negative. Salmonella belongs to gram negative organisms. So we need to remember the thumb rule, gram positive and gram negative. Each side which know what are all the organisms is a common likely organisms. He told pharyngitis, pharyngotonsillitis, 80 to 85% virus. Only hardly 5 to 10% bacteria. Among the bacteria, group A beta hemolytic streptococci. Similarly, pneumonia most likely virus, but some bacteria like strep pneumonia can cause pneumonia. Staphylococcus can cause Moraxella, gram negative. Even though pneumonia gram positive, sometimes Moraxella and Haemophilus influenza is a gram negative can cause. Atypical like Mycoplasma, Chlamydia, Legionella. These are all the organisms. So we need to know what is the common 3 or 4 organisms that you need to remember. For that, you need to attend sessions conducted by AMS regularly as well as CGP regularly. But in the hospital setting, the ball game is entirely different. For example, I told earlier, the person might be colonized with some gram-negative organisms even in the throat. Gram-negative or gram-positive organisms can colonize in the urinary tract also, enterococci. So in a hospitalized patient, you cannot apply the rule of above the diaphragm, below the diaphragm. Above the diaphragm, below the diaphragm, only for a community-acquired sepsis use the rule. But hospitalized patients, ICU patients, particularly antibiotic-exposed persons, do not consider this rule. That's more important for you. So we need to know each site, what is a common 3 or 4 organisms. You can search or we can provide training for you. I'm creating newsletters. That newsletters commonly updating what is happening. We are coming with more data. I just shown in last couple of slides how to update your knowledge on organism-specific ideologies. So we need to know urinary tract means mostly E. coli, Klebsiella, Proteus, Serratia is possible, but rarely other organisms like Enterococcus or some of the Staphylococcus. Staphylococcus, the pathology is entirely a different process, but it can happen. Keep in mind. So we need to know top 3 organisms in each site. That we can provide you more data for you people that don't worry about it. So remember, for the syndrome, we need to remember what are the 3 or 4 common organisms in my part. For example, in Coimbatore, what is more common? In Trichy, what is more common? So we need to remember the 3 or 4 organisms that is more important for you. Unless you remember, that is very difficult. But only we are working on it. We'll show in a couple of slides there. So this is called India UTI map. We are collecting all the publications happen. So these are all observational data, I know. This is not a randomized control trial. This is not a prospective data. This is a retrospective data, but it has got publications. Publications in some journals. We are searching different places. What is the 3 organisms according to different sites? For example, Tamil Nadu, what is common? For Kerala, what is common? We are working on it. This is called UTA map. This is community-acquired pneumonia. If you see the 3 organisms, Streptococcus is still common, but country like India, gram-negative Klebsiella can come into the community-acquired pneumonia part. I told them mostly gram-positive is causing the pneumonia, but data shows some of the gram-negatives also can cause. But we need to figure out what is the percentage in my part. That is more important. Staphylococcus also will cause it. Keep remembering it. This is skin and soft tissue. So we are working on a different areas map based upon the publications we are giving it. That's more important for you. This is meningitis map. So we are working for individual organisms, individual syndrome. What is the 3 bug? Because this is more important for you instead of cut copy paste the Western guidelines. For example, IDSA guidelines or European guidelines or even Harrison textbook of medicines. You cannot copy. You need to know what is happening in your part. That is what we are working on it and giving it to you. Don't worry about it. So this case now what I'm going to do? People say symptomatic therapy. How you decide it's symptomatic therapy? This is why the score what doctor, my previous speaker clearly alluded, this is called CENTA score. Presence of fever, that's why high grade fever, not like 99, 101, 102, yes. Absence of cough, most likely bacteria. Presence of purulent exudate, not some congestions. Congestions indicate virus. Purulent means bacteria. Cervical lymph node, that too painful node. Some people uses age also criteria, but adult populations not much importance. Usually 4 criteria, 0, 1, even 2 also there is no need for antibiotic. 3, yes, we can give antibiotic. You want to do the cultures or if you want to do the screening, that is fine. But clinical, at the point of care, you are practicing in the rural part. I don't have access, please. This is a good thing, you can do it now. So this is a case I shown as a 4th case. Most of the people say this patient needs antibiotic. Patients say this patient needs antibiotic. Again, I want to go for it. Sit back. So you need to answer right now. So how many people are sitting there? Initially they sat here, but I want to check. Sorry, I just don't know what happened. Something happening. Yeah. So what I'm going to do now? I just want to see how many people thinking now to give antibiotics. Still people say, I just want to check what they're doing. Deep right now. People are changing, no antibiotics. Initially they said antibiotic for this case, now changing the mind. So people are moving to what do you call the webinar mode. In webinar, people always say, yes, this is a possible. That's what people are telling it. So we need to remember. I think my screen is fine. So we know the organisms. For example, the diabetic food, the initial stages gram positive, later stages gram negative. Even further, some anaerobic organisms can grow, that we know. But we need to remember the most important thing. I covered so far, write the diagnosis. For write the diagnosis, take proper history and do physical examination. Write the syndrome, I told first part. The second part, what I told you. So once you made the diagnosis, we need to have some validated syndrome score. For example, Blair score. For example, for a streptococcal pharyngitis, use a CENTA score, this type of scoring system. Now people want to do a lot of investigations. For example, the wound swab. there is a rule called garbage in and garbage out. Never send wound swab. For example, if you do a swab of your skin and send it to the microbiology lab today, or do a throat swab and send it to the microbiology lab, your throat will contain Klebsiella pneumoniae, Pseudomonas aeruginosa, Acinetobacter pneumoniae that is resistant to carbapenem. Your skin contains MRSA, your skin contains VRE, your skin contains maybe gram-negative organisms. But we are not treating with any antibiotics. That means it is colonized. For example, what are all the sites is a pure site, what are the sites impure site? For example, blood is a pure site. Even in the blood, what happens if you are not taking the skin, not cleaning the skin before drawing the blood cultures, the skin bacteria can go into the blood culture, sucking the needle, it can go inside and contaminate the blood cultures. Coagulation negative stuff can happen. Similarly, throat is not a clean area. Urine is not a clean area. What are all the clean spaces? CSF, blood, joint fluid, peritoneal fluid, pleural fluid. We need to aspirate. So this type of cases, tissue is needed, not the wound swab. Suppose if you are not able to take the tissue, at least what we need to do, when you saw some pus, don't send the pus immediately. Wash it, go to the base, wash with a normal saline, go to the base, at least that is the second best option. Instead of doing a wound swab without doing a washing or something, that is going to show colonizer. We want to get a true organisms. For getting a true organisms, get a good sample. For example, if you want to make a diagnosis of sepsis or septic shock, send sufficient blood. For example, 25 to 30 ml, ideally 40 ml of blood is required. 40 ml. I studied my undergraduations, post-graduations in Stanley. I never saw a blood culture proven Salmonella typhi in Stanley. Why? Because I sent 2 ml of blood, 3 ml of blood, one bottle. But now I am seeing daily 5 culture proven. We never do white oil in our practice. We do only blood cultures. Without blood culture, some other shortcut like Eastopenia, we are using it. That's fine. But blood culture I'm getting. Why? I send minimum 20 ml of blood for blood cultures. Ideally, I'm sending 40 ml of blood. Because of the 40 ml of the blood, I'm making the diagnosis right now. That is the reason for it. So send appropriate sample, send appropriate volume also. Not only the diagnosis needed. Similarly, for the blood cultures, we need to send appropriate. For example, TB meningitis. We want to make a TB meningitis as a diagnosis. How much CSF we need to send? I'll wait for a minute. I want to check people how much CSF they're sending. Just type. I've not given any choices here. Just send how much CSF you are sending to make a diagnosis of TB meningitis. Just type it. People say 10 ml. This is all webinar answer, but in real world, people are sending 0.5 ml, 1 ml. To make a diagnosis of TB meningitis, published data shows 6 ml of blood, 6 ml of CSF is required. So when we write the TB meningitis CSF analysis, I write 6 ml of CSF for expert MTB or gene expert or CBNAT. So we send sufficient volume. For blood cultures, minimum 20 ml. We need to take appropriate sample, not the wound swab, appropriate sample. That is more important. In infectious disease, diagnosis is most important. To get a diagnosis, proper history, proper examinations, proper investigations. Unnecessary investigations we don't want. We need to do proper investigations. Unnecessary investigations are like Vidal, MAN2, TB quantiferon. These are all unnecessary. One blood culture bottle. Urine cultures without urine routine. Always when you think the person has got UTI, when you put a bladder score shows more than 4. You need to send urine routine. Presence of pus cells may UTI, may not UTI. Absence of pus cells rules out UTI. Catheterized patients, you are thinking the person has got UTI because of the catheter. Send a culture. Freshly put catheter and send one sample for urine routine. If pus cells are 0, 2, 3, 4, 5, even some of the studies show up to 10 pus cells, UTI chances are a bit low. At least more than 5 to 6 pus cells may not. Ideally more than 10 or ideally more than 15 are plenty, may not. Again, it is not confirmatory. It may be due to UTI, may not be due to UTI. But absence of pus cells, I'm looking at the negative predictive value. Absence of pus cells rules out UTI. So don't say the person has got E. coli more than 1 lakh. If I see the urine routine, no pus cells, I say this is asymptomatic bacteria, even because of the catheter. Keep in mind. That is, you need to remember. So you need to know what test to send to make a diagnosis before starting antibiotic. So starting antibiotic, history, examinations, proper investigations. Unless you do the proper investigations, bit difficult. Now the person is hypothyroid, diarrhea 4 times. This is a case 3. I put here for your people. So what do you say? People say, how many say I want to start antibiotics here? Is there any score? How many say I want to start diarrhea 4 times? If you do the audit, that's a real scenario. But what is your webinar answer here? Can you say the webinar answer here? Webinar answer says no, that we expected there. But in real life, people say some antibiotic and preferred antibiotic also. I'll come back in a minute. What is your preferred antibiotic? I know what you are prescribing because we are doing a lot of audit of your prescriptions. So we know what is your prescription. The score here, for example, UTI bladder score, pharyngitis Senta score. For gastroenteritis, the score is called AGE, acute gastroenteritis score. A stands for appearance of the stool. Presence of the blood or presence of the mucus in the stool, 1 point. Presence of a graded fever, high grade fever, 1 point. Presence of more episodes of stools, more than 6 episodes. E stands for episodes of stools. G stands for grade of fever, high grade fever or fever. And one is called appearance of the stool, A. Appearance of the stool, blood or mucus. Graded fever is present or not. More than 6 episodes, this person might need antibiotic. Why? It indicates the person has got large bowel diarrhea. When a person encounters the diarrhea, we need to make whether it's a small bowel diarrhea or large bowel diarrhea. Small bowel diarrhea, the episodes are less, frequency is less, but volume is more. In large bowel diarrhea, the episodes are more, 20 times, 25 times, but volume of the stool is minimal. In large bowel diarrhea, blood will present. Small bowel diarrhea, only watery stools. Large bowel diarrhea, stangry. They keep on want to go and pain will be there, fever will be there. So these are all the indicators. Small bowel diarrhea, no need for antibiotics because this is mostly viral. Large bowel diarrhea, probable bacteria, we need to give antibiotics. What are all the bacteria I need to cover? I need to cover common 4 organisms. Salmonella, Shigella, Campylobacter, Yersinia. Usually E. coli do not treat. Particularly aggressive, hemorrhagic, don't treat. If you treat, it worsens the thing there. So don't treat. So we need to put a score called AGE score. AGE score again 0, 1. Usually one of the 3 parameters. Presence of appearance like the blood and mucus, yes. Or presence of more episodes, yes. Presence of fever with diarrhea, yes. So we need to know what is the situations I need to use antibiotics. So this is another case I not shown initially. 72-year-old male, fever, chills, dysuria, vomiting, no bowel disturbances, vitals are stable, loin tenderness is present, urine routine is pustules, urine cultures E. coli, sensitive to nitrofurantoin and meropenem, resistant to ciprofloxacin, ceftriaxone, amoxicillin, and cotrine. What is your antibiotic? So you decided now what is your antibiotic of choice. This is very important. I'll spend 1 minute here. I want to see your responses. Please go ahead and vote. I think out of 800 people, only 16 or 17. I think the organizers will seriously rethink about giving certificate for the people. So nitrofurantoin only people are answering. So we need to know about our antibiotic. So far, what I covered, what sort of host I need to treat the patients, how to make the diagnosis or how to think about your bug. That's what the 2 parts I covered. Now I'm switching my gear to decide how to start the antibiotic in your practice. That's what I'm doing right now. Couple of people say meropenem. First thing, whether this patient needs antibiotic or not. Yes. Why the patient needs antibiotic? I put the bladder score. Fever, 1 point. Dysuria, 2 points. 1 plus 2, 3. Person has got some urgency not mentioned, frequency not mentioned. So the person, so far the history shows only 3 out of 7. But we need to go back and ask any frequency, urgency. If it is present, 4 out of 7. Here urine routine showing pustules, may not. So the person has got fever, the person has got dysuria, and the person has got pustules. So UTI may present, may not present. So chances of treating is okay. But here the person is an elderly patient. So I need to think about my threshold bit low. I told elderly people and newborn my threshold is bit low. The urine culture is growing. Sensitivity is nitrofurantoin. How to choose between nitrofurantoin and meropenem? Nitrofurantoin is a good drug. Unfortunately, nitrofurantoin will not go to the kidney. Where is the infections? The person has got fever, chills, and dysuria. The infection is upper UTI. It is not in the bladder. Bladder means any antibiotic will work. Pyelonephritis means antibiotic will work in the microbiology lab. But antibiotic will work in the real life. We need to do. So this person has got UTI means I need to check whether there is infections. Pyelonephritis. Pyelonephritis, nitrofurantoin, oral phosphomycin will not penetrate the kidney, will not penetrate the prostate. So we need to know the antibiotic spectrum. First thing, whether the bacteria cover or not. Nitrofurantoin cover E. coli, it cover Klebsiella, it cover your gram-positive like enterococci also. But nitrofurantoin has got a couple of holes. For example, Pseudomonas nitrofurantoin will not cover. Similarly, meropenem will cover E. coli, Klebsiella, Serratia proteus. Only thing, carbapenem resistance. I shown my initial data. The sensitivity of meropenem came back from 99 to 50%. So we need to know the sensitivity. Even though initially originally covering, for example, in US, meropenem will cover still 90%, 90% working. In India only it is 50% working. So we need to remember what is the resistance pattern in my country to the antibiotic. And we need to know what are all the organisms causing UTI. E. coli, Klebsiella, Proteus, other enterobacteria like Serratia, Pseudomonas, and Enterococci. For example, if you see the nitrofurantoin is good for E. coli. Nitrofurantoin is good, green color. See the fifth column, last but fifth. So I show the arrow mark here. Nitrofurantoin, E. coli is sensitive. Klebsiella will work. Proteus, it is inherently resistant. Other enterobacteria may not. Pseudomonas, it is not working. Enterococci will work. So this is called the spectrum chart. If you have the spectrum chart, we need to decide, suppose these are all the three common organisms in my part. UTI means either E. coli or Klebsiella or Proteus. Then I think I can use nitrofurantoin if it is lower UTI, not upper UTI. If it is upper UTI, I need to use agent like ciprofloxacin, either levofloxacin or cotrimoxazole. Unfortunately, cipro is resistant here, so I need to think about IV antibiotics. Instead of meropenem, ertapenem is once-a-day injections. Similar to the meropenem, again, ertapenem won't cover Pseudomonas. So we need to know the spectrum, antibiotic spectrum, that is more important. For example, here, levofloxacin, ciprofloxacin, moxifloxacin, all are fluoroquinolone. But levofloxacin cover gram-negative and gram-positive. Ciprofloxacin won't cover gram-positive. Like streptococci, staphylococci, cipro is not a good drug. It is good drug for gram-negative, good drug for Pseudomonas. Moxifloxacin, good for gram-positive, good for anaerobe. It has got good TB action, but gram-negative Pseudomonas big zero. So don't think all fluoroquinolones are same. We need to read, we need to know the antibiotic spectrum. Unless you know the spectrum, it's very difficult. So what decides the antibiotic spectrum of the antibiotics? Second thing is a dose. If you give an antibiotic, whether it reaches the urine or not, for example, tigecycline, minocycline, this will work in the lab. If you check E. coli with the tigecycline, it will work. But when the patient has got UTI, tigecycline is excreted to the liver. It won't go to the kidney. So tigecycline is not a good drug for UTI. So we need to remember what is the missing spectrum. For example, if you use meropenem will not cover MRSA. Meropenem will not cover your VRE, vancomycin resistant enterococci. Meropenem will not cover carbapenem resistance. Initially, it may cover because of the resistance, carbapenem resistance, gram-negative it won't cover. So this is called the spectrum. For example, nitrofurantoin, I told E. coli it is good, Klebsiella is good. What is the whole? Proteus it won't cover, Pseudomonas it won't cover. That is the whole. So when somebody prescribes, some of your practitioners prescribe some other antibiotic, don't throw his prescriptions. I want to see the prescription, what you written, what antibiotic you written. Despite receiving the antibiotic, fever is persisting means the antibiotic has got a hole. The antibiotic has got a hole. I need to change the antibiotic based upon what is my diagnosis, what antibiotic used. So always see the prescription given by your previous practitioner, that is going to help you out. And this is called the pharmacokinetics. For example, ampicillin and amoxicillin, both are same. Spectrum-wise, both will cover similar organisms. Ampicillin penetrates the brain well. Amoxicillin will not go into the brain. Nitrofurantoin is a good drug for lower UTI, cystitis. It has got no penetration into the kidney. It has got no penetration into the prostate. Even though E. coli, lab says nitrofurantoin sensitive. But we need to know the pharmacokinetics. Whatever antibiotic I'm giving, whether it reaches particular site or not. Today we had discussion just before afternoon. I got a patient with a lung abscess. Amikacin sensitive. The patient has got ceftriaxone sensitive. The clinician calling me, amikacin, I can give an IM. Why don't I give amikacin? I told amikacin is a good drug working in the lab. Unfortunately, it is a good drug for UTI. Amikacin is not a drug for lung abscess. It won't penetrate. The penetration of the abscess, particularly anaerobic environment or even in the abscess environment, amikacin has got very poor penetrations. Even though lab it is working, in real life it won't work. So this is called pharmacokinetics. For that, you need to understand whether the drug reaches particular level or not. That is more important. And one more concept is oral antibiotics. Patient does not need IV antibiotics for everything. We can give oral antibiotics provided it has got good absorption. For example, ciprofloxacin, levofloxacin, good absorption. Linezolid has got good absorption. Cotrimoxazole, good absorption. And clindamycin has got good absorption. What are all the antibiotic that will absorb? Suppose if we give 100 milligram, how much it go into the blood? That is more important. And most important thing, safety. What is the pregnancy category? Or what is the toxicity concern? I told amikacin, the person is 70. The pulmonologist want to give amikacin. I told 70 plus AL, his creatinine is 1.5. If I give amikacin, whatever kidney functions is going to lose. So think about the safety, think about the pregnancy category also. Then most important thing, I want to check 1 minute here. What is the dose of cefotaxime? Because cefotaxime is a bread butter job. What is the dose of cefotaxime people are using? I'd like to see your prescriptions. What is the dose of cefotaxime? With real heart, don't webinar answer, please real life answer I want it. Cefotaxime, not cefixime, cefotaxime. Taxime otherwise. So some of the pediatricians work also. I think adult dose I wanted. I make my questions, clarifications clear. What is the adult dose you are using for good? So people are giving it. So fortunately, the webinar answer is not coming here. This is the real answer coming. So if we know what is the dose, antibiotic depends upon not only spectrum dose. The dose of cefotaxime is 100 to 150 milligram per kilogram of the body weight. Always think like a pediatrician's milligram per kilogram. So 60 kilogram man, 100 mg means 6 grams. 6 grams means 2 grams Q8 hourly. During my undergraduation, my internship, or during my post-graduations, 1 gram BD. Who invented the dose? We do not know. Why gram negatives are resistant in India more compared to US? This is the reason. Underdosing. Don't underdose the patients. If you give underdose to the patient, this will happen to you. So that's what remember. So give the maximum dose. For example, people never give cefotaxime. People never give cefotaxime. 1 second, I'll just make it bigger. Sorry. Okay. So patients, for example, cefixime. People are using 200 milligram. The dose of cefixime is 8 milligram to 15 milligram per kilogram. That means 400 milligram I need to use. Unfortunately, none of the people are using 400 milligram. That is why most of the company, not most of the company, almost all Indian companies stop manufacturing 400 milligram. If you want to raise 400 milligram cefixime, I ask the patients to 2 tablets. People saying you are giving overdose, but that is the correct dose. Ciprofloxacin, the correct dose is 750 milligram BD. So use the maximum dose. Why it is needed, I'll come back in a couple of slides later. So one, we need to know the spectrum of antibiotic, whether the spectrum is good or not. Second thing is called pharmacokinetics, whether the antibiotic reach particular site or not. And third thing is a maximum dose. And most important thing, I am not told. This is Alexander Fleming during his Nobel lecture. First thing, whether you want to use antibiotic or not. Second thing, what is the dose, maximum dose. Third thing is called minimum duration. Previously, people want to give longer durations. Now minimum durations. Pneumonia 3 days, UTI 5 to 7 days. The thumb rule, any patients in OP 3 to 5 days, in the ward 5 to 7 days, ICU 7 to 10 days. That's the rule. But exceptions are there. Endocarditis, meningitis, osteomyelitis, different story. Similarly, bacteria does not know whether the antibiotic comes through oral or IV. Oral is equal to IV. There is no randomized control trial. IV is superior. Oral antibiotic with good bioavailability, use the oral antibiotic. Don't think IV is a superior one. And if you want to make these things are very difficult. So I told you how to choose antibiotic. First, write the diagnosis, make a syndrome. Second thing, think about bacteria. Above diaphragm, think of gram positive. Below diaphragm, think of gram negative. Third thing, in antibiotic, spectrum you need to know. Pharmacokinetics you need to know. Safety is more important. Pregnancy category, renal toxicity and everything. And fourth thing is durations and oral therapy is good. Use the oral therapy. Now it's very difficult. We are coming with some of the ChatGPT tool. Instead of asking a ChatGPT, now everybody is using ChatGPT. Instead of asking everything, we are training the model. Instead of internet data, useless data, we are training with the latest medical literatures, giving the ChatGPT. These are all the matrices you want to give. For example, this case, a 25-year-old healthy male presents with a mild cough, throat congestions, low-grade temperatures, and a small non-tender lymph node. What is the complications? He says, according to ICMR, because I trained this model with ICMR guidelines. As per the ICMR guidelines, no antibiotic is indicated. This is called antibiotic coach. So you can use because you don't have ID specialists everywhere. So we are bringing this model also to you people. Those who are interested, keep messages us. So once this model is fully trained, we are training the model now. Once it's fully trained, yes, it should not hallucinate. It should not tell some wrong information to you people. But human in loop, we'll be there in the loop. Don't worry about it. So we take the responsibility before the answers goes to you there. Don't worry. So we need to know local epidemiology. That is what we are working. India map, I'm working on it. We need to know what common in my hospital, what is common in my locality. That we need to know. That also we are working on it. Don't worry about it. So the right patients should receive, right antibiotic you should receive, right dose you need, right durations. The right duration is a short duration. Right dose is a maximum dose. Right patient is patient infected with bacteria is a right patient, not with the virus. That's what we need to remember. So first thing, whether decide antibiotic needed, write the diagnosis. What is the antibiotic? Depends upon the spectrum, depends upon the pharmacokinetics, depends upon the safety. The third thing, what we need to know, maximum dose, minimum durations. So if you want to learn more, we already wrote the algorithms book. We are creating a newsletter, updating whatever knowledge we are getting, what is latest publications. You are busy practitioners, you are not able to go and search it. Very difficult to attend every day. AMS programs or other things. That is why the newsletter will come to your point with the WhatsApp. And we are bringing the antibiotics tools, whatever we discuss now. We are writing an antibiotic tool for you people there. You can get the antibiotic tools also instead of reading a big books. Practically, for example, comparison between tetracyclines, comparing between azithromycin, clarithromycin. We are comparing what is the differences, what is the dose, what indications I need to use, all spectrum. What is the level in the CNS, what is the level in the lung, so we can give the color code. If it is not reaching the lung, we can make it red. If it is reaches 40 to 50% or 50 to 60% yellow, something is like a good 80% above green color. So it depends upon the antibiotic spectrum, depending upon the pharmacokinetics. We are giving this booklet. This booklet is under preparations. Shortly, it is going to release. Those who are interested, keep following us so that we can get the booklet. So this is called the spectrum: gram positive cover, gram negative cover. What is the best? What is not there? The book is practical oriented, not a theoretical one. So don't worry about it. You have to think about it. So any questions I'm happy to take. Yes, your people are well versed with diabetes and hypertension, but this is very important for you. If you know antibiotics, you avoid legal lawsuits. So if you come in a big car, if the patient files a lawsuit because of your poor antibiotic selections, whatever money you earn, hard-earned money, you lose and you want to go back with this mode. So to avoid this type of things, learn antibiotics, learn better way, learn with the books and everything. Thanks for the wonderful opportunity provided by Dr. Sendil and AMS team and Dr. other coordinators and other speakers. He wanted to take a little longer because I usually hurry my slides. So you want to speak a little lower. That's why I consume my next speaker's time also. I'm happy to take any questions in the future. Please put it in the chat box. I can answer it. Usually in my time there. Or my contact number is also not my contact number, but best of IDs, everybody knows it. Send it there. So you can send it to the WhatsApp so we can reply back to your questions. Thanks for the opportunity. I stop sharing here.
Hello.
Yes, sir.
Am I audible, sir?
Yes, you are audible, sir. Your slides are also visible, sir.
Slides are visible?
Yes, sir, visible, sir.
Yeah, okay. Thank you very much, sir. First of all, I thank the organizers of this talk, IMA AMS group. And after listening to two powerful talks from 4 o'clock, I think all of our brains have got exhausted. So I'm not going to take much of your time. But when Dr. Sendil sir was asking me to choose a topic, I thought of introducing this topic because this topic has been with us for more than a decade. But when it started somewhere in 2014 and 2015, when WHO has come with the concept of One Health concepts, nobody took it seriously. It to be very true. But thanks to COVID, I think today we have realized the importance of relationship between human health, animal health, and environmental health. And today, after when Dr. Suresh sir was talking about data, today we have to be creating data in our own setup, like he was mentioning about the prevalence of infections across various infections across India. So like that, today we have to document, we have to publish and create data for our own country so that we can have our own guidelines in future to come. So with this small introduction, we'll go to the topic. Just a minute. Slides changing there?
Not changing,
One
sir.
second.
It's not changing.
Yeah, one second.
Not changing, sir. Not changing yet.
Just a moment. Is it changing now?
Yes, sir. Yes, sir. It's changing. It's changing.
Yeah, thank you. Yeah, so the objectives of my talk, let us look into the historical aspects, whether this One Health concept is new or it's been there for a long time. And let us define this One Health components, One Health, and let us find out what are its components. And most important of this talk is its relevance in today's context. As I said, even though WHO advocated almost 10 years back, today, every country, including Government of India, has come out in a very big way on this particular issue. And I'll be showing a small video at the end of my talk to know what are the government initiatives and how it's being implemented in our country. So this One Medicine, One Health, and One World has been there, as you can see in this slide. Virchow, a German physician and a pathologist, he said so many years back, there should not be no dividing line between human and animal medicine. And also coming to William Osler, who taught, it's a very, very interesting information, who taught medical students at McGill College, as well as he was teaching the veterinary students at the Montreal Veterinary College in 1870s. So there is a strong relationship is established long time back between the animal health and human health. And Osler, William Osler, also published the relations of animals to man and promoted comparative medicine and One Health concepts. So again, you can see from this, even starting from Hippocrates before Christ, he has mentioned in his work on airs, waters, and places, and you can see so many scientists have talked about this. Now we'll come to the definition of One Health, what we are trying to explain. First, each word what's being mentioned has got a lot of meaning in that. So it is defined as a collaborative. I think the future slides you will be seeing nearly more than 25 departments are operating, and it should be a collaborative, as I said, multi-sectoral and transdisciplinary. I think this is very, very important. Cutting across the specialities, we have to work together. That is why it is called as transdisciplinary approach, working at not at the highest level or only at the local level. It should be a vertical program starting from the local, that is from practitioners, IMA doctors, or from a government primary care till WHO. So from the local level, regional, national, and global levels, with the goal of achieving optimal health outcomes, recognizing the interconnections between people, animals, plants, and the shared environment. It's a very beautiful definition of WHO. And you can see this is a logo of the WHO, where you can see all the three are strongly interrelated. So we should have one health and one planet and one future. Again, this picture shows that you name an animal, we can name a disease which can be transmitted. So what we popularly call as a zoonotic disease. So it's not only from animals of this nature, these are all mammals, even from other animals. For example, when you're talking about environmental issues, I think recently you would have seen the cholera outbreak in one of our northern countries. Similarly, when you're talking about vector control, again, it relates to environmental issues. So when you talk of animal, environmental, and human health are very, very strongly interrelated. This is a very interesting slide. This is very, very important for us to know why we are talking about this One Health concept. And when actually these slides were prepared almost 10 years back, at that time, we didn't know about COVID. But today, after I think all of us who are listening to this talk would have experienced the COVID pandemic. So let us understand this particular slide even with that context. For example, when you say these are the resources, so these resources can be even domestic animals like this, or it could be a wild animals like this. So the infections which are happening in and around the animals, either it is a wild or a domestic animals, there can be a spillover to humans. I think we know what happened in COVID in China wet market. It got transmitted from the wet market to the humans. So once it enters humans, the human amplification starts. So if you just look into the number of days needed, you can just see that even within 1 to 2 months, maximum 1 to 2 months from the humans or from the animal source, it can enter the human population and gets amplified. And all of us know that the travel has become so fast. Today, they say within 72 hours, the disease can spread anywhere in the world from one point to another point. So such is a magnitude of the travel industry and spread diseases can occur. That is where reporting of early symptoms and signs, especially of contagious. For example, today, one of the most common thing after COVID is the respiratory influenza viruses. Even in ICMR and the Indian government is having a strong surveillance, which I will talk later. So again, these are the old things. We have almost every day we are seeing some new things are emerging. So when you're talking about zoonotic diseases, which already we have been going through in our practice, there are re-emerging diseases like scrub, Kaisanur forest disease, leptospirosis are again re-emerging. Apart from that, newly diseases like our Congo hemorrhagic fever or your COVID for that matter, H1. Again, all of us are very familiar with the Nipah virus. Again, bird influenza, bird flu, which again on and off we report somewhere in Kerala, whether it can spill over to our state also. So why this is happening? This is very, very important. Why we are able to see the emergence and re-emergence, why we should be cautious. One is, again, I already mentioned about traveling, globalization, and unprecedented expansion. I think this is, we are entering into the domain of the animals, into the forest or into the other places where they were there. Now we are trying to enter their areas. Of course, environmental changes causing global warming, and of course, rapid internalization and use of pesticides. In fact, some of the creatures like vultures that are getting extinct because of misappropriate use of NSAIDs like that. So a lot of changes in our farming system, deforestations, as well as unplanned and uncontrolled, especially poor sanitation and water supply is a very big issue which is affecting our own country. Again, interface. Today, a lot of pet animals are being are there in our own house. Apart from today, we can see a lot of dogs, which is again another big problem which we face in our street animals. Again, a development of microbiological adaptation like resistance. Sir was also mentioning about antibiotic resistance. So antibiotic resistance happening in milk in a cow can be transmitted to the humans also. So it's not only the human resistance, it's a animal husbandry practice also. And of course, we have got more diagnostic capability and surveillance, which makes us more diseases to be diagnosed at a very early stage. These are a few factors that contributes to emerging and re-emerging diseases, which I think we have, for want of time, I just go through only the names, which all of us, we are aware of that. Nipah and West Nile, we have heard about that, especially in Kerala. Again, monkey fever, that's another newer term that we are coming across. And this Crimean Congo hemorrhagic fever, this is particularly common in Gujarat. The people who are handling camels, they are more likely to get this, and already few cases are reported from Gujarat, Ahmedabad. Again, rabies, which all of us know, scrub is a very, very common problem in our state, which most of us are managing in day-to-day practice. I already mentioned about influenza like viruses, which again, surveillance is going on. We have already faced the Middle East respiratory syndrome, SARS, like that. And again, on and off, these have this bird threat is also always there. So this is the various, one of the main problem why these new viruses are emerging is because of the genetic drift and genetic shift, which I will explain to you. Like, so we have heard of this culling of birds, animals like that. Yeah. So this is a very important slide, which why all these emerging diseases comes with so much of variations. What we call it as here, for example, you will take the example of H1N1, popularly called as swine flu. So actually the swine flu virus, how did it emerge was already the bird avian influenza is there. So already pig has also got a virus. So the mixing of virus, for example, some virus from these birds entered pigs, from ducks is entered this pig. Already pig has got two viruses already. So all these four viruses interact or they get assortment. We call it as genetic drift and genetic shift. So these drifts and shifts occur in the pigs and a new virus emerges, that is H1N1. Again, it becomes a humans. So that is why we are talking about animal-human interaction is another important triggering factor for emerging. And these kind of resistance or new variants occur in the animals. Again, we have to be very, very conscious of this bioterrorism. All these new emerging viruses can be used as a bioterrorist weapon. So already we would have heard about this anthrax attacks like that. So what are the lessons we learned? Again, they say we are talking about infectious diseases. Nearly 60 to 70% of infectious diseases what we face in our day-to-day practice are zoonotic. So they are related to our animals only. They are expanding geographical regions. And today we have excellent diagnostic tools for early diagnosis. That is why surveillance has become the order of the day. We have to look for any emerging diseases so that we are aware of its clinical presentation as well as about its spread and prophylaxis, personal prophylaxis. So all these things, again, the most important as far as our IMA doctors, why I'm talking to these people, to us is, we have to share the information. Today, we have a strong system called IDSP, Integrated Disease Surveillance Program, where they collect data not only from government institutions, but also from the private doctors and labs. So unless we share the information and we have our own strong database, it's very difficult to predict the early emergence of infections. And also especially regarding quarantine, especially when the COVID emerged, even before COVID, we had a threat of Ebola. So that time I was working in MMC. So really we were prepared to isolate this Ebola if at all we are going to get it. So early emerging diseases must be not only identified, they must be quarantined, for which we should know the protocols. So these are various departments which is operating. In the last video in the end, I'm going to show you a video how the Government of India has taken various initiatives. So these are the various list that we have to. For example, I was talking about data. So data is very, very important to predict the outcomes as well as predict the emerging things and coordinations. Knowledge management. Sir was mentioning about AI. I think today everything revolves around AI and a lot of predictive modules. Predictives, even during COVID, we are able to predict how many beds we have to have, how many cylinders of oxygen we have to have. So the knowledge is going to be, the AI is going to help us in predicting our thing. And regarding laboratory, I think Nagpur in our country, Nagpur has established the disease for all newer emerging diseases. We'll be seeing that in the video. And we should have the quarantine check post facilities. And we have to have emergency response systems. Animal surveys, again, we had a lot of experience during the COVID on the functioning of seaports, airports, quarantine, awareness of all the generation plans, not only to the public in the schools and colleges also. So apart from that, we should have about the legal issues. We should closely work with the veterinary people regarding the zoonotic activities. And we should also monitor the piggery units, slaughterhouses. In fact, there were COVID cases reported in wild animals. In fact, we went to wild zoo and we saw how the swabs are being taken for even wild animals. So there should be a strong network among the veterinary doctors also. So these are the various legal, I was mentioning about legal component, and we have got, for example, reporting of infectious diseases is a mandatory according to the Public Health Act, which has been again revised recently. So this picture just shows the umbrella where this One Health concept is covered by so many people, and we have to be collaborative and we have to be transdisciplinary in our approach. So this is a slide I want to share because this slide was taken long time back, almost 10 years back. I was sent, we are preparing preparation in our infectious disease ward, where you can see model wards and other things. And in fact, Dr. Kulandeswamy sir was also standing there, and we are talking about negative suction theaters, all those wards and other things. In fact, this picture was taken during that time. This is a picture taken pre-COVID, 2015. And one of our postgraduate, you can see, just we wanted to show the future of practice is going to be like that. And within 4 or 5 years, we really had this thing. And in fact, this person was also infected with COVID that time. Later. So why I'm telling is, thanks to COVID, today the awareness of infectious diseases, emerging, re-emerging diagnostic facilities, role of microbiologists, reporting, everything has got a relevance in today's context. So this is the National Health Mission. You have heard of National Health Mission. Now, part of this, they have formed a National One Health Mission. So this is an initiative of the Government of India, and principal scientific advisor to Prime Minister heads this particular organization. And you can see the what are the stakeholders in our country. So this particular slide talks about the various departments which is meeting. I think this now started functioning since 2 years. They have multiple meetings. So what I would request to is just look into the website of One Health Mission and get updated on the various guidelines, emerging and re-emerging diseases that you can see. So what I will do now is I will just play a video now.
World we live in, the health of people, animals, and environment are closely connected. When one is at risk, all are at risk. That's because diseases can easily cross between animals and humans, eventually affecting the environment as a whole. The National One Health Mission provides a holistic framework by uniting human, animal, and environmental sectors and enabling seamless cross-collaborations to address the control of infectious diseases and develop capabilities of pandemic preparedness for the nation. It's time.
Raghunandan sir, actually, we are seeing only the PowerPoint. If you can.
Oh, video is not coming?
Yes, sir. You can just
Okay, sorry.
Close the PowerPoint and then play the video and share that window alone, sir.
Yeah. Thank you.
So, principal scientific advisor.
So it is same, sir. It is same. Now only you have switched it off. Now you can share the window of the video alone, sir.
Animal health and environmental.
Is it seen now?
Yes, sir. Now we can. Yes, sir. Now seen, sir. Thank you.
Yeah, I'll just go from the front.
By implementing several important activities. Disease surveillance, which plays a vital role in safeguarding public and animal health by enabling early identification of emerging threats and tracking their progression, especially at the intersections of human, animal, and environment. Creation of the national network of laboratories dedicated to disease, outbreak investigation and response is a major achievement of the mission. This network will cater to samples from all sectors and play a vital role in detecting and containing emerging health threats. Additionally, a standing national joint outbreak response team, having representatives from all relevant sectors, has been formed to ensure a coordinated response to outbreaks. This team has played a key role in the management of Nipah virus outbreak through multi-sectoral collaboration of National Center for Disease Control, Indian Council of Medical Research, Department of Animal Husbandry and Dairying, Ministry of Environment, Forest and Climate Change, and other departments. The National One Health Mission also facilitates data sharing and seamless data integration among different sectors to enable informed decision-making, development of critical medical tools like vaccines, therapeutics, and diagnostics, and building a skilled workforce through capacity building programs. Initiatives like the National Referral Center for Wildlife by the Ministry of Environment, Forest and Climate Change contribute to the mission's ability to manage wildlife diseases through a One Health approach. Anchoring the National One Health mission is the National Institute of One Health, Nagpur, which coordinates the One Health efforts in the country and serves as the nodal point for the global network of One Health institutes, established as an outcome of Chief Science Advisors' roundtable discussion under India's G20 presidency.
All these efforts can only be truly effective when we work together across center, states, stakeholders like academia, private sector, and multilateral organizations, and citizens, thereby realizing the vision of One Earth, One Health, and Health for All by Honorable Prime Minister.
The National One Health mission invites the citizens of India to connect and engage with the mission to promote build a resilient and interconnected system for improved health and well-being of humans, animals, and the environment.
Okay, thank you. So just you would have seen the video that what are the various efforts we are taking from the government of India. So to conclude, I want to give some take-home messages. One Health has come to stay. We have to work together. There is a lot of surveillance programs. So if you see any increase in any particular type of diseases or any particular type of respiratory outbreaks are there, definitely we have to be screened. Already the surveillance, they are taking samples, random samples from different parts of our country. And All India Institute of Medical Science along with ICMR is doing a continuous surveillance of influenza-like viruses. So like that, if you happen to see any unusual symptoms and signs, it's a responsibility of practitioners in our state. We have to report to the public health authorities who will try to investigate and prevent the outbreak. So let us have one health, one concept in our practice and make healthy India. Thank you once again for IMA Association for giving this opportunity. If there is any question, we'll take it up. Over to Dr. Sendil, sir.
Thank you, Dr. Raghu. That was a wonderful lecture. Nice to see you through this forum. And good to see 680 people staying till the end. So if there are any questions, kindly unmute yourself and the speakers are here, you can directly ask.
Good evening, everyone. So thank you, Sendil sir. So I thank the IMA TNSB state team, our president, Dr. Sridhar sir, and the state secretary, Dr. Thiraviyam Mohan sir, and state finance secretary, Dr. Solomon Jaya sir, for their august presence in our first AMS IMA TNSB webinar, which is exhaustive and covered a lot of topics. And I also thank our immediate past president, Dr. Sengatuvan sir, and the president-elects, Dr. Ravi Kumar sir, Dr. NRTR sir, and immediate past secretary, Dr. Karthik Prabhu sir, for their presence here and felicitating the occasion. And overall, I thank all the three speakers for their exhaustive and exuberant presentations. And all the three topics selected were very useful for all the departments, irrespective of their specialities. So Neminathan sir is known to all. He is very well versed in pediatric emergencies and challenges. And it was well taken, the topic. And Dr. Suresh Kumar sir and his audacious presentation on selecting the right antibiotics. So it's very useful for almost all the audience here. And the new topic, which was relatively new to all of us, but it's existing for a long time, it's a One Health, which includes the health of human beings, environment, and the animal health. And that was also well presented by the third speaker, Dr. Raghunandan sir. So overall, I thank all the speakers, and above all, thank all the audience for the continuous presence. We had almost 850 plus at the peak and of the audiences, and I noted some of the members are still not members of IMA. So I request everyone to become members of IMA so that they can utilize these kind of academic opportunities like IMA, CGP, and AMS, and also other benefits of Indian Medical Association. They can contact the local branches to become the members of the IMA. And overall, I thank our colleagues and AMS new team, our chairman, Dr. Nirmal Frederick sir, and Dr. Sendil Kumar sir, for the wonderful work in executing the first online CME and of AMS. And we are looking forward to have the next CME in February in North Zone.
Sir, one second.
Yes, sir.
Mohammed sir, a short question. I could not unmute. That's why I had a small Dr. Ravi Kumar here.
Yes, sir. Yes, sir.
A short question.
Yes, sir. Please.
Regarding the diabetic foot. I am a diabetic care person. Bacterial biofilms, sir. How to handle that bacterial biofilm? a short answer from any of the.
I think Suresh Kumar sir should be the ideal person here. Sir, is
So
Suresh
yes,
Kumar sir
doctor,
is?
biofilm is a big challenge, not only for a diabetic foot, any implants, any prosthetic valve, there is a big problem. So usually the source control is more important for the, but couple of antibiotic like rifampicin might be added to overcome the biofilm because it need to penetrate into the bacterial capsule. Biofilm is nothing but a covered nega protections or bacteria is growing inside. So the ideal treatment is debridement. Or if you are not able to do, use some of the agents, biofilm active agents like rifampicin to be added to get away with the biofilm, sir.
Thank you so much. Thank you.
Sir,
I'm
Dr.
Dr.
Sundaramurthy
Jake.
here.
Sir, I'm Dr. Jaikmar from Namakkal, sir. Can I ask a question?
Yes, sir. Sir, there are already 4 questions in the chat box. Number 1, there is a question about the dose of oseltamivir. Please remember, in children, there is a pyramid called influenza pyramid. In your OP, 90% of the influenza or mild one, they are called category A, for which oseltamivir is not required. It is required only in 10% of the cases. That is category B and category C. The dose of oseltamivir is 2 to 3 milligram per kg per day, 2 divided doses. It should not be given rampantly, misused, because if you misuse oseltamivir, then the flu virus will get resistant to this. As Ravikumar was telling, we are celebrating Antimicrobial Resistance Day. We'll be in soon when we misuse antivirals, we'll be celebrating Antiviral Resistance Week. So do not misuse oseltamivir. Second question was platelet transfusion went to what count below what
Sir,
count?
one second, sir.
Yeah.
Adult dose is 75 milligrams twice daily for 5 to 10 days. Especially in children, we give it for a longer time also. Adult dose 75 BD.
Adult dose is 75 milligram. Of children more than 40 kilos also, it is 75 milligram BD. Okay. The when to give platelet transfusion, please remember there is no prophylactic platelet transfusion as per WHO recommendations. Even if the child bleeds, the bleeding may not be due to platelet thrombocytopenia. It could be due to other reasons other than thrombocytopenia. So even in a bleeding child in dengue, you have to give packed RBCs first. The bleeding persists, then second dose of packed RBCs, then FFP, finally platelet. So do not treat the platelet count, treat the patient, not the platelets. And the dose of doxycycline is 4.5 to 5 milligram per kg per day. It's given once a day for 5 to 7 days. The question was about teeth staining. Now that FDC has approved the usage of doxycycline even in neonates. So if you use it for less than 7 days, there is no question of teeth staining. And last dose is about availability of cloxacillin. Cloxacillin is available as syrup form as Nexiclox. It is 100 milligram per 5 ml cloxacillin. So these 4 questions were there. And regarding AK Ravikumar's question about biofilm, as rightly told by Dr. Suresh, you had to first remove the film completely, because that is you are reducing the source control is very, very important. And the drugs very, very important. Most of them are methicillin sensitive and methicillin resistant staphylococcus. That's the main cause for this one. So probably you need to use a longer dose of drugs like oral linezolid for a longer time to control these organisms, apart from rifampicin.
So, Nami sir?
Yeah, please. You can ask questions. Yes, sir. Sundaramurthy sir, please go ahead.
Yeah, flu vaccine in pediatric, எந்த ஏஜுக்கு மேல போடணும், அது limitation இருக்கா?
Please. Yeah, in flu vaccine, there are 2 vaccines. One is a live vaccine, which is given about 2 years of age, intranasal, should not be given for pregnant mothers. It is at present not available. Second is inactivated influenza vaccine called IIV, which is available now. It is a trivalent vaccine which contains H1N1, H3N2, and influenza B. This vaccine is given for children above the age of 6 months. Below 6 months, transplacental antibodies are there, not required. From 6 months of age up to 59 months of age, up to 5 years of age, we need to give. And adults above the age of 65 years, we need to give. All children with comorbidities, irrespective of the age, we need to give. children on steroids, on immunosuppressive drugs, you need to give. Children who have or those who have taken stem cell transplant or organ transplant, you need to give. And this is a must vaccine for all doctors who are attending this conference, because we are all high risk people. All doctors should take this vaccine. This can be given along with concomitantly with other vaccines in children. Even in children with egg allergy, this can be given with caution. The annual dose is required because there is an antigenic shift every year that happens. So flu vaccine strains keep changing. So every year you need to take. There are two vaccines, Southern Hemisphere and Northern Hemisphere vaccine. Southern Hemisphere vaccine comes in the month of April, May. So the Northern Hemisphere vaccine comes in the month of August, September. So any of the two vaccines, since Tamil Nadu is near equator, you can take either Southern Hemisphere or Northern Hemisphere. Whichever is early, you can take. So the message is flu is a vaccine that is mandatory, should be taken by all practitioners. Now there is a strain called influenza A H3N2 clade K. This clade K is not available in this vaccine, but fortunately there is a cross protection of the vaccine that is available, strain that is available. So though there is a new strain that is circulating after this vaccine was manufactured, but fortunately the present vaccine is giving protection against this new strain called clade K of H3N2.
Excuse
So
me,
one
I'm Dr.
common question to
Jaykumar
all
from
the
Namakkal,
speakers.
sir.
Yes, Jaykumar,
Sir,
please
keep
tell
moving,
me.
sir. Keep moving.
Jaykumar,
Sir,
please go ahead.
so one chinna discussion, sir, with Raghunandan, sir. One of my friends from UK, her name is Shanti, non-medico. Actually, she gave me a call. She wanted to do some project with the help of our IMA, sir, like sterilization of the stray dogs and then immunizing, prophylactic immunization of public. They want to sponsor it. So I want guidance from Dr. Raghunandan, sir, regarding this. How to go about?
Please go ahead. Myself and Raghunandan sir, we are very much involved in rabies. So please give my number to her and ask her to contact me. I'll also coordinate with Raghunandan sir. Already Raghunandan sir, I want to appreciate Dr. Raghunandan sir for his award, for his activities on rabies. So last year
It's an award from Global Alliance for Rabies Control, sir. So
Yes,
just
sir.
with humble, I want to say that this year I have been awarded as the medical educator from Global Alliance for Rabies Control. It's a global award which I received last month. And as far as research work, as Dr. Neminathan said, now I am the director of Advanced Medical Research Institute at MGR University. Definitely we can collaborate, sir.
Yes, sir. I'll
Definitely
connect
we can
with you,
collaborate,
sir.
sir. Please give me her number and both the numbers. Both of
Yes,
us
sir.
are willing to do it. I'm also part of Association for Prevention and Control of Rabies in India. That's called ACRI. So we'll do it at national level.
She's very
So
much interested.
one of the recent verdict by the court regarding the street dog is the more accidents are due to stray dogs. So that is the current
Yes,
court
sir.
verdict.
Yeah. You are absolutely right, sir.
So regarding
Thank you,
One
sir.
Health,
Thank you,
only
sir.
one suggestion, sir, regarding One Health.
Yeah.
The major challenge for One Health in India is alternative system of medicine, sir.
Okay.
Do you agree, sir?
Sir, we have to take the best out of every system, sir.
இல்ல அந்த ஒன் ஹெல்த்ல
Because
வந்து ஒன்லி நம்மளது மட்டுமா அலோபதி மட்டுமா எல்லா மெடிசனும் வருதா?
actually, they have included, if you have seen that particular slide, even Ayush is part of that thing. That is where I'm saying we have to take the best out of Ayush system is supported by Government of India as a separate ministry is there, separate wing is there. So definitely there are certain areas where definitely we can look into them and we need more research. That's what I was telling. We need evidence-based approach.
Thank you, sir. Raghu, sir.
And also regarding one vaccine, sir was mentioning about flu vaccine. I think I would even strongly recommend pneumococcal vaccine. I think that is also very, very important, especially for people with diabetics and hypertensive with comorbids more than 50. It's a 2-dose vaccine. We can take one and after a gap of 4 weeks, we can take another dose. Definitely it has a impact on the avoiding this infections in our population. So I would recommend pneumococcal also, sir.
And repeat after 4 years, right, sir?
Pardon?
Repeat the vaccine after 4 years, right?
No. 4 weeks. 4 weeks. 4 weeks.
4 years கழிச்சு ஒண்ணு போடணுமா
இல்ல
booster?
சார் இல்ல சார் only 2 doses are recommended, sir.
Okay, thank you.
I think there are no more further questions. So if at all any questions is there, you can post the questions even in the AMS groups. There are totally 4 groups as of now by IMA, TNSB, AMS. So you can post the things, and also this entire webinar is being recorded in YouTube and it is available. The link is already shared in the AMS WhatsApp group also. And once again, I request all the members who are not members of IMA to become members of IMA so that they can have this academic benefit continuously. And I request you all to join us for the next CME in February in North Zone, and the details will be posted in the respective WhatsApp group. Thank you all. Thank you once again, and over to our IMA TNSB AMS Secretary, Dr. Sendil sir. Dr. Sendil sir or Nirmal sir, any closing remarks, sir?
Yes, Ibrahim.
Yes, sir.
So you concluded the vote of thanks. It's been a wonderful program, and happy to see such high quality academics being discussed. So we'll meet again with yet another program. So February 15th, there will be a North Zone AMS meeting at Tambaram, and following that, we'll have the monthly webinar. So we'll keep you updated, and thank you all. Happy evening.
Thank you, sir. Thank you all.
Thank you, Dr. Nirmal sir, Dr. Tem, Dr. Sendil, and thank you, Dr. Abdul.
Dr. Muhammad Ibrahim, sir.
Muhammad Ibrahim, sir.
Sorry, I was calling you Abdul Ibrahim. Sorry, Muhammad Ibrahim. Thank you, my fellow speakers, Dr. Raghunandan sir, Dr. Suresh. So it was an excellent meeting organized. My appreciation to the new AMS team under the leadership of Nirmal. I'm sure you will cross all the records, and I'm sure this team will create more history, bring more laurels and colorful. The flag will be kept very high at the national level and also at the international level. Wishes to the entire AMS team and all the delegates who have attended this meeting. Thank you. My co-speakers are wonderful speakers. My sincere thanks to them. Thanks to everyone.
Thank you so much, sir.
Thank you, sir.
Thank you.
Experience and expertise mattered a lot. And
thank you.
Thank you, Raghu. And thank you. I think Suresh has left. He's still. Thank you, Dr. Suresh.
Thank you, sir.
Thank you, sir. Thank you, everyone.
Welcome.